only have the attendance joined.
Namaste and greetings. I, Reetlath, researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evang Niti Anusandhan Sansthan Nai Delhi, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the last day of Women's Sexual and Reproductive Health Across a Lifetime, an online national summer school program, a 4-day immersive online certificate training course. This training program is organized by IMPRI, Gender Impact Studies Center. The chairs for this program are Professor Vibhuti Patel ji, visiting Distinguished Professor IMPRI, and Dr. Manorama Bakshi ji, Director and Head of Healthcare and Advocacy, Connoisseur Adversary, Founder and Director, Trilok Raj Foundation, visiting Senior Fellow IMPRI. This program also has an excellent panel of experts who will be sharing their expertise for the duration of this program. The distinguished expert panel for today includes Dr. Sangeeta Rege ji, Director of Center for Inquiry into Health and Allied Themes, Jihad, visiting Senior Fellow at IMPRI. Dr. Amar Jesani ji, Independent Researcher and Teacher, Bioethics and Public Health, Editor of Indian Journal of Medical Ethics, visiting Senior Fellow, IMPRI. Dr. Anant Bhan ji, MBBS, MHSC, Bioethics, Researcher in Global Health, Health Policy, Bioethics and Mental Health, Mentor and Principal Investigator, Sangat, Bhopal, India. And Dr. Sanjida Arora ji, Research Officer, Center for Inquiry into Health and Allied Themes, Jihad, Mumbai. The panel of convener comprises of Dr. Simi Mehta ji, CEO and Editorial Director, IMPRI, and Dr. Arjun Kumar ji, Director, IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and efforts into understanding emerging issues pertaining to women's sexual and reproductive health, while helping us to bring together the practitioners and participants through this impactful course for policy research and action. We've also shared the course outline and reading resources in your email for your kind perusal. Before we start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be a Q&A session after each presentation. Share your questions on the Q&A box. Ensure that the questions are not posted as anonymous attendee. Ensure that your questions are precise. And lastly, refrain from making general comments in the question to save time. Now, without any further ado, let's start our program. It is my honor and privilege to first of all call upon the chair of our program, Professor Vibhuti Patel ji, to start the program with her opening chair remarks.
Thank you, Reet, for introducing the program, and welcome all for this 4th day and the concluding day of this online immersive certificate training course on women's sexual and reproductive health across lifetime. Thank you, Dr. Arjun Kumar, Dr. Simi Mehta, Ms. Priyanka Negi, Ms. Vaishali Singh, for conceptualizing and implementing this whole idea into this course. And we also welcome my co-chair, Dr. Manorama Bakshi ji, and anchor, Reetlath. First, a small recap of the event that has transpired throughout these 3 days. So on day 1, we had a very important presentation on the perspectives on reproductive health and sexual health and reproductive autonomy, reproductive freedom, and so much of conceptual clarity came about the whole discourse on the sexual and reproductive rights. The Professor Vina Vaswani's presentation was on comprehensive maternal care, both antenatal and postnatal maternal care. Dr. Padmaja Samant-Mavani, she spoke on the question of consent, legalities, and also the challenges that women face when they are violence and double standard of sexual morality and the response of the medical fraternity. On day 2, Dr. Kamakshi Bhate made a very, very sensitive presentation on adolescent health and nutrition and she also, it was based on her rooted experience of in Bombay communities, Bombay slums for last 4 decades. Dr. Anamika Priyadarshini, she shared the findings of qualitative research on adolescent self-conception, self-identity, mind-body, the dialogue, and the societal response to the adolescents. Dr. Swati Rane's study on menstrual matter was based on the work that she has been doing with the college girls in Mumbai, with the among the economically weaker sections of society. And she also brought out the issue of menstrual hygiene, stigma, and solution, which resulted in a very interesting discussion on isolation of girls and women during menstruation, still practiced in so many rural and tribal areas of our country. And yesterday we had a very, very enlightening and what you call the mind-boggling sessions. One about the dimensions of gender, sexuality, and reproductive wellness. Dr. Padmaja Samant-Mavani enlightened us about, and she debunked the myths around sexuality and put forward the facts with regards to sexual health and role of healthcare professionals when they are approached by survivors of gender-based violence. Dr. Anuradha Somni demystified the myths around menopause, social determinants of loss of self-esteem among aging women, and so many taboos subjects which are there regarding the menopause, women's fertility, the whole myth about motherhood, and women who are not unable to produce babies, and stories of self-actualization and empowering experiences of the findings of Bahar, the organization with which she's working, was very important. And this valuable narrative gave us hope that similar experiments, similar models can be evolved in different regions and different locations. Dr. Aksha Seth's very enlightening presentation was about the deconstruction of terms such as decriminalization, pathologization, medicalization with regards to trans person, and introduction to rainbow economy. It was a new knowledge for all of us, and eye-opening understanding about unexplored areas were also taken up by Dr. Aksha Seth, which also resulted in a very interesting discussion. Now, today, the focus is on, again, the very important global and national policies on population stabilization and the various types of new reproductive technologies that have that have been applied. India, as it was told in the first day, that India was the first country to adopt a family planning policy. Here we need to understand the difference between birth control, which is a decision of individual or couple, if there are two people are involved in producing babies, whether to have baby or not, at what interval, what kind of contraception to use. But the moment we talk about the family planning, it becomes the state comes into picture. Now, we have seen that after the debacle on forced sterilization during emergency rule in the 70s, whole population regulation has shifted entirely onto women. Women are shouldering the major burden of the population control programs. And it was after 1975, the slogan that was popularized in India after the World Congress on Population in Bucharest was the development is the best contraceptive. But at the same time, what we see that the vertically imposed population control programs, which also generate a lot of human misery, which is encapsulated and captured by Deepa Dhanraj's film called Something Like War. The women's movement has had a long battle against hazardous contraceptives. The issue of abortion, India, we did not have to fight for abortion. Women's movement did not have to fight for women's abortion in 1971. It came as one of the methods of contraception, the question of safety also, that unsafe abortions were posing major hazard for women's lives. So what we needed was a medical termination of pregnancy. The question of assisted reproductive technology currently in the 21st century has been a very important industry in terms of various types of technologies, whether it is IVF, in vitro fertilization, or ICSI, or GIFT and ZIFT, they are being used. So I think we are going to have a very interesting session today, where with the 4 experts, Dr. Sangeeta Rege, Dr. Amar, Jesani, Dr. Sanjida, Arora, and Dr. Anant Bhan. Thank you very much.
Thank you so much, ma'am, for such a comprehensive overview of our sessions till now. Now, I'm delighted to call upon Dr. Manorama Bakshi, the co-chair of this course, to share her opening remarks with the audience.
Thank you, Reet. Thank you, ma'am. Thank you, Chair, for your opening remarks. First of all, like ma'am said, the past 3 days have been incredibly enlightening for me as well, like listening to the panelists. Today, I'm eagerly awaiting like enriching discussion and learning opportunities that will come across for all of us, for the larger global good and for women's sexuality and sexual health. Even though like Government of India, we have reached out to reversible TFR, that is now 2, and the fertility rate has been on decline. If I will talk about like in 1966, the TFR was 5.7 births per woman, and today we are 2. However, despite remarkable achievements, challenges, and other things we went through, which Madam already spoke about during the emergency time, but particularly still there are some of the challenges, even though we have reached the reversible level, mainly when we talk about the unmet need, especially the contraceptive needs we are talking about. So as we move forward and we look at the adolescent girls and women in rural areas, I feel that it is imperative that we need to have a multifaceted approach. Strengthening along with the infrastructure, we need to have strengthening the service delivery also, community engagement, awareness raising, and advocacy. So the kind of, we have actually achieved the success that further needs to be like whether the basket of choice is there for every woman, even though the basket of choice is provided by the Ministry of Health, but how we can retain those kind of things. So women are accessible towards it. There is much more evidence. The usage of contraceptives and including the condoms. We know that condoms is the only, barrier against the STDs, HIV, and the HPV. But somehow like are these kind of things known to each and every woman? So there are so many things we'll be delving into, we'll be talking about. And I see as we approach in the final day of this course, which will delve into topics such as contraception, STD, family planning, abortion, ART. So I look forward to very enriching discussion, and I will come further a little later. Thank you. Thank you, Reet.
Thank you so much, ma'am, for setting such a positive tone for our discourse today. Now, it is my honor to invite Dr. Sangeeta Rege to start the program with her keynote address on the topic Contraceptive Advances, STD Prevention, Family Planning and Awareness. We welcome you, ma'am.
Thank you very much. I'm just trying to open my slides here. For some reason, I am unable to see my slide. Just tested it and I don't know what's wrong. Sorry.
IMPRI team has, no? The
Yeah, I don't know
PPT
why
as well.
it's not.
Is the PPT on, ma'am?
Yeah, it is. I mean, we just did it, right? 5
Yeah,
minutes
yeah.
ago. So
Ma'am,
I'm
But
go
it
to
doesn't even show share screen. nahi aa raha hai.
share
there is no-
screen.
There is
Then
no share screen.
you see a pop-up window.
no, it should. I'm just not able to. For some reason, just give me 1 minute.
Can you click
I think
share
after
screen?
we did the video, it's probably the settings changed or what I'm trying to. Sorry, I'm just not able to. In the interest of time, do you just want to share it?
Yes, we will.
Yeah, thank you. Good evening, friends. Thank you, the IMPRI team and Dr. Manorama and Dr. Vibhuti for your, you've actually set the tone for what I am going to speak. Two disclaimers. I'm neither a medical doctor nor an academic one. I'm a social scientist, and I'm hoping that I will soon get to complete my PhD. So I'd just like to state that and place it on record. The topic that has been given to me today is quite vast. It looks at contraception versus family planning. It also looks at STI prevention and so on. I will try and just kind of touch upon and introduce these different concepts and also try and complicate it a bit. But I will not have the time to do a deep dive on each of these. So I just wanted to kind of come in and say that. Also, the internet is a bit quivering, so I'm just going to switch off my video and then switch it on at the end of the session. Host, can you share screen?
Yes, ma'am. Yes, just a second.
Sure. Yeah, thank you. If we can go full screen. Yeah, could you please go to the next? So, you know, one of the learnings in adult learning is what I have learned is to start with something which is more interactive rather than have it as a didactic style. So I bring to you a case study, and you know, you can also read it for yourself. But the name of this person is Bharti, and she's 21 years old. She's studying at a university, and she's recently found out that she's 8 weeks pregnant. You know, she is the first person who's migrated from her village and is attending higher education in the city and in a university. She has been in an intimate sexual relationship for the last 2 years, and the couple has decided that they will marry once both of them stabilize, her partner gets a job, and so on. They have been engaged in protective sex using condoms. So because they did not want to kind of at that point either conceive or have a pregnancy. Unfortunately, it's quite possible that the condom fails sometimes, and in this case, it has failed, and and Bharti is now pregnant. Her friend has advised her to go see a doctor, a gynecologist, and so she's gone to a private clinic. Over there, while the doctor says you're pregnant, the doctors found out that Bharti is single and she's not married. And so there is a refusal to actually conduct medical termination of pregnancy. Bharti is scared, she is worried. She's checking the internet to find out what can she do and whether she can access abortion by the pill, which is a medical abortion. In this period, about 4 weeks additionally have elapsed, and now she's at 11 weeks of pregnancy. The chemist has already told her that, that she will have to buy a particular one, that she can't get the usual pills for rupees 500 because she needs a prescription from a doctor. And he's advised her to buy another medication. There aren't any specific instructions given to her. Of whatever she's understood of misoprostol, she's taken 4 tablets. By evening, she's developed cramps, bleeding. It could have been severe. By now, her boyfriend is quite worried, and he's actually taken her to a general practitioner, not a specialist. The GP has gone ahead and advised her to do ultrasound. And the ultrasound actually shows that the medical abortion is not in fact complete, and there could be several reasons for it. That there are remnants of the products of conception in Bharti's body still. And finally, a gynecologist she went to has agreed to do a DNC, which is the curettage. Now Bharti has to shell out 5,000 rupees from her pocket, and she will have to end up either borrowing it or pawning something to be able to rid herself of this unwanted pregnancy. The case of Bharti, I would say, is not very rare. This is extremely common across the country, in cities, in villages, in districts. So I would like, colleagues to take a minute to think through what do you think could have been done differently by the doctor or by the chemist? And what do you think could have been messages that were either supportive of Bharti when she disclosed about her pregnancy? And can you think of any actions that the providers could have taken differently so that Bharti had not just a safe abortion, but also an affordable one? So I will request participants to either put it in the chat box or just unmute yourself and quickly respond. All of you have read and heard the case study, right? So, any thoughts that come to your mind? Do you think this is a rare issue? That Bharti is a one-off person who's experienced, denial? Any thoughts that come to your mind about this case, please just put it in the chat box, even if they're not, connected to these questions, but any generic questions or comments that come to your mind after having heard this case study, they're most welcome. Okay, maybe we'll go to the next slide and, as you think through it and if something strikes you, please feel free to put it in the chat box.
Can I offer my insights, ma'am?
Yes, please.
Ma'am, I think this is not very uncommon, and it also largely showcases how the whole ecosystem of the medical practitioners and also those engaging in the intercourse interact with one another. And I'm not sure whether the boyfriend went along with the girl, but when things took a wrong turn, then perhaps he had to be along with her. I don't know.
Yeah. No, thank you very much. And you've as rightly said, in fact, just reiterating from the case study that the friend is the boyfriend who has actually been with her through thick and thin in this particular, journey of accessing safe abortion. And if you know in India, there's a law called the Medical Termination of Pregnancy Law.
Yes, ma'am.
Which actually allows for people who are 18 and above to be able to access safe abortions. But unfortunately, there are several notions that find their place in the minds of medical and nursing professionals because they belong to the same milieu like all of us. And, all of us are exposed to the same stereotypes or biases that only pregnant, only married people can be pregnant. And if they're unmarried, then, they should not be engaged in sexual activity. And the same is seen in the case of this person who's actually an adult, but who is unable to access this kind of abortion because of the mindset.
There is one comment by Ashna Mehtaji who has written, health provider should have confirmed for age, and if it is legal, she should have helped to send to government center for proper help.
Yeah, absolutely. So as you've rightly said, the government sector, but also private sector, because the law is very clear that a registered medical practitioner with a certain amount of training, and there are certain numbers of abortions that they're supposed to be doing under supervision, after which even an RMP can carry out this kind of abortion. But unfortunately, there is very little awareness and knowledge, and this entire fear grapples medical providers, and that is why they are in a position of inaction. So thank you. Let's go to the next slide.
Deshmukh ji, you can, she wants to speak. Miss and Lakshmi Chetri also wants to speak.
Yes, yes, Lakshmi ji.
Shubhda ji, you can,
Sorry, I have written and she has.
Lakshmi Chetri ma'am has mentioned the health provider should have given her counseling.
Yeah, I mean, I absolutely agree with you, Miss Lakshmi.
Okay. Over to you.
So, there are a couple of notions. I think many of us who've completed our education, you may have either heard or read this as young as when we were in school about population explosion in India. And, also terminology like the poor people breed because they have nothing else to do and they have multiple pregnancies and multiple children and they crowd the public system. So, all of these seven notions have occurred in either text forms or is something that is reiterated as stereotypes in communications in different systems, not just in the health system, even in general parlance. And, I would like to understand what you think of these. Something like India's population is growing rapidly. I think Manorama ma'am clarified that right now the total fertility rate is about 2.6 for India. So that itself is a myth. This entire issue of higher population density leads to lower economic progress got very recently debunked by a research report. I'm trying to recall the name of this Indian organization. Yeah, it's the Oxfam India, which has debunked this myth, the third myth, because they very clearly indicate that about 70% of aggregation of the country's wealth lies with about 7% of the rich in this country. So really, there is no correlation between higher the population, poorer is the economic advances. Similarly, this entire aspect of family planning improves women's reproductive health itself is a notion because I think Dr. Vibhuti in her opening very clearly explained how did the entire program related to family planning enter India. And, it has been increasingly critiqued because it does not take into account women's autonomy, women's bodily integrity. And so there is a huge concern with this kind of language itself. Also to end by saying that, if we incentivize people who do not use contraceptions, they will start using contraceptions. This is really extremely problematic because usage of contraceptives is useful for people in general and for their own health. And it's not just in the context of reducing unwanted pregnancies, but to improve sexual health and to keep oneself safeguarded from all kinds of STIs, including HIV and others. So this also is a myth. Despite all of these being myths, sitting in 2024 and looking at family planning program, which is, I think it's called the FP 2030, which again has certain targets given for the family planning 2030 about how you can reduce the population growth and so on. One of the big challenges is the manner in which this entire issue of, giving targets to medical and nursing providers have come in. So while they do not say in black and white that these are the targets for you for sterilization or for tubal ligation, there are different ways in which these targets are now being set because the language has changed. So the targets may be set not just for doctors and nurses working in district hospitals, but they could also be made for community health workers, for ASHAs, in different ways where you do not see in black and white or in a written policy that we want you to control population or the number of, or limit the size of a family. But the entire language is kind of vicarious enough for the provider to understand that it is a target for him or her. And so this is something that is still underway. Next. Briefly, I will talk about a context-specific thing that the organization that I belong to has done. It is about conceptualizing the issue of gender in the light of contraceptive care. So this constant harping of the terminology family planning is problematic. Because if you look, and I'm sure you must have studied in the past, that the term family itself is a patriarchal term. Because a family usually comprises of a heterosexual couple, which is a man and a woman who is married and have children. And as we are advancing, we are also learning that there is no one single form of sexuality or sexual orientation or gender identity. And the entire approach of family planning keeps people away who do not conform to this heterosexual relationship. So given this approach, Sehat has conceptualized an understanding on contraceptives, which are gender sensitive, not just for women, but also for people in same-sex relationships, as well as those who are transgender and intersex. So if you see the current approach in the health system, it's largely gender blind because all of the targets are primarily focused only on women. There are absolutely no mechanisms to encourage trans people, intersex people, or gender fluid people to be able to access contraceptives easily over the counter, either in a public setting or in a private setting. There is adequate research to indicate that often they may go to quacks or to babas. The affording ones may be able to go to the private sector, but the number is very little. The entire brunt of family planning falls on women, especially post-delivery, which in itself is problematic. Often doctors will come back and say, but we have taken consent from women. We all know that consent is often, unfortunately, understood as a simple signature on paper, and it should not be. And I'm sure that other speakers after me will deal with this issue. So if you see on the right side, there are certain, supportive directives, either through policy or through plan of action that India is a signatory to. And it actually allows for people to create a gender sensitive or a gender enhanced, a gender informed health systems response to the issue of contraception. And I think that that is something that needs to be adapted in the existing clinical practices. Next. Yeah, this is a simple, slide that I had just picked up from one of our resource persons who actually trains extensively medical students and his colleagues. So if you look at the prevalence of the nature of PPIUCD, which is postpartum intrauterine devices, this was a study that was done in 18 facilities, and this is kind of, almost 3 to 4 years old. But what came out of the study was immediately after delivery, most women were actually subjected to an IUCD insertion, but only 63% women were aware that this was done. So, procedurally also, often healthcare providers were not even informing women that they were inserting PPIUCD after their deliveries, which in itself is problematic. Also, the current guidance in the Indian as well as global context is very clear that contraception counseling has to begin in the antenatal period. It cannot begin, once a woman has delivered, because that is not the time that the woman is in a mindset to really discuss through the different contraceptive alternatives that are available to her. But we often see that, doing any contraception counseling in the antenatal period is almost like a lip service. Often providers tell us that, we are compelled because we have targets to achieve. So it's almost like a double-edged sword. Next. Yeah, this is another study that was actually done by the United Nations Family Planning Association in collaboration with the government of Maharashtra. And here too, some of the observations of the study were these, which are quite shocking because the study is not even, I think, 6 years old. Just the physical standards of care in public health facilities like the primary health care or rural health or municipal hospitals is actually almost suboptimal. I mean, dogs in health facilities, OT protocols not being followed, no space for counseling. Complaint boxes were not available. Also, we don't know what happens when people actually complain and, who analyzes that data, whether it is responded to. In 18% of cases, consent was not taken. Even in the actual surgery, 70% women were probably not offered anesthesia because they were found to be wincing during the surgery. So if you see, this is the state of affairs as far as the existing contraceptive care or lack of care is concerned in India. Though the studies of Maharashtra, I wouldn't be surprised if we find very, very similar observations in different parts of the country. Next. So these are the World Health Organization principles. For those of you who belong to the health sector, or even those who are public health professionals or masters in public health, you will all be exposed to this. These principles need to be implemented in toto. But we all know that this does not happen. Discrimination is experienced not only on the basis of class, but also caste and religion. And there is a lot of evidence coming from people who belong to the Dalit community, those who belong to the Muslim community, trans men and their access to contraceptives, people in same-sex relationships, that none of these are followed when they access healthcare services. And it's unfortunate that when you actually speak to healthcare providers, they will often say that we treat all patients the same. But, is equity about having the same lens for everybody? Or is equity about adapting, and understanding a context and providing your services? Is the larger question in front of the medical system today. Next. So a few thoughts on what do we think can be done? Can we do something in the programs that are really related to the government programs, whether it is the Family Planning 2030, whether it's the entire, contraceptive related policy of the Ministry of Health and Family Welfare, whether we need to tweak. We know that the medical termination of pregnancy law has had several amendments. It is forward-looking. But then what is ailing the medical system on the ground that keeps people away from actually enabling access? What needs to be done with medical providers in the system who are currently working? What can be done to change their mindsets? To also offer them comfort to say that, if you carry out ethical practice, that will not impinge or have a negative impact on you. You're supported by not just law, but law and ethics. What can we do in the medical education system? That is, in a system before medical students become practicing medical doctors. There is one thought which is very clear, and that says that catch them young, catch them when they're studying in medical education, because, they're not as jaded, for lack of better words, but they're not as jaded as those in the in-service, system. And so it's quite possible that younger medical students, if they're exposed to different social determinants of health, to understanding how health is experienced, and is beyond a biomedical model, it's quite possible that you may have a new crop of gender-sensitive and gender-informed medical educators and doctors. Yeah, next. So I have brought to you a simple box here. As I said in the beginning, Sehat collaborates with different medical colleges in India to really make efforts to bring in a gender lens to the medical education, which is the MBBS medical education. And one such effort has been done, with the curriculum for the gynecology and the obstetrics, as well as the community medicine. I'm mentioning these two disciplines because they very closely teach issues of contraception, family planning, and so on. So this is one of those topics where a module has been developed, which actually targets what is the knowledge that the student should have, what is the skill that the student should acquire so that they can probably implement it in their internship, and what is the attitude with which it should be done. So, it is put upfront that students must be made aware of coercion and control which is close to intimate partner violence and something I think was discussed yesterday as well, which actually puts women away from being able to use contraception. So even if you have a basket of choice available or made available for women, there could be something at home or in the intimate relationship that does not allow for women to use contraception. And that awareness among medical students is important. Similarly, giving or offering them a language of reproductive autonomy, that it is ultimately the person who, whose body may bear a pregnancy. And so that person has complete right on determination of whether the person feels comfortable in carrying out a pregnancy or not, which kind of contraception suits the person or not. It's not really the decision of a medical provider, or not basis the convenience of a medical provider, that I find it easy to do a tubal ligation or to put a IUCD rather than something else. So it cannot be a provider-driven contraceptive. It has to be people-driven, and it has to be based on what people expect as contraceptions. So that is the difference that one is trying to make through engendering medical education. And I think just an environment of respect, because increasingly you see the distance between medical students or educators and people who are accessing at least public health services is increasing by the day. And given this huge gap of many other social determinants, including class, we increasingly see that medical students just can't relate to the population that comes to them. And that's a huge impediment, because simply because you cannot relate to the people who come to you, there is a high possibility of othering them, and then forming biases and having stereotypes about them. And that is something that I think all of us as a community of health providers or health advocates need to chip at, because that is really something about the perspective. So clinical skills, can be offered, can be explained, can be taught, but it's the overarching attitude that needs to change as far as the medical providers is concerned. Next. Yeah, these are just two features of, what comprises a human rights perspective. I'm sure you must have learned about it yesterday as well. But this is to also kind of critique the manner in which the entire policy and planning happens in India. At one level, we are signatories to ICPD. At another level, the language of our policies does not even take into account gender fluid people, people who are single, and so on. So the underlying principle continues to be family planning. Imagine we are sitting in 2024 and we still have a family planning 2030 as a policy. So I would say that that itself explains the problem in the terminology. Next. These are just some principles that have been put over here. As somebody, I think, a little while ago spoke about, the doctor should offer counseling. So when we are saying counseling, we are saying uphold human rights of people who are accessing contraception. It is not counseling to convince them that, PPIUCD is better or tubal ligation is better. But it is in the interest of the person who is accessing contraceptions, so that the person is able to enjoy a good sexual and reproductive life, right? So it is person-centered, not provider-centered. And that, I think, is the difference. Currently, we lack the language of doing couple counseling in most of our public systems, and I'm sure even private systems, to bring a couple to the space of contraception and discuss something that is suitable for both, something that both agree upon, does not happen. It only happens, the male partner is only brought into the picture in instances of infertility, and that needs to change because contraception is not the responsibility of women. It has to be shouldered by both individuals in this context. And also, you will all know now that you have the injectables as contraceptions. There is a huge debate about it going on, for, against, and so on. So there should be a disclaimer with the entire range of consequences that can happen with injectable contraceptions. Often these are offered to people who are economically underprivileged, under the duress that you can switch off once you take the injection for 6 months and you don't have to think about it. So, the entire conceptualization of the package is very simplistic, but it does play a havoc on the reproductive health of women. And also long term, what can be the consequences are still being studied. So that is another slippery slope. And I think that the full disclosure for injectables have to be explained to women in this context. Next. Yeah, this is just a reiteration of the same thing: full choice, free choice, and informed choice. Next. Yeah, this is just my summary of what is the ideal role, I would say, for a doctor to understand the difference in family planning and contraception, and to recognize the diversity of contraceptive needs in people. Right. And as Professor Vibhuti said, one of the most impinging important factors is intimate partner, domestic violence against women that can actually impact their access to contraception. And let's really, you may have seen the NFHS 5, which is not very different from the NFHS 4, where I think male usage, I think vasectomy is at about 4 to 5%. Vis-a-vis, women's implementation of contraceptive, which is, I don't know, 43 or something percent. So what is happening? What are the fears that men have, as far as the, vasectomy is concerned? And there are so many myths. And while some effort is made to debunk the myth, I don't think adequate efforts or movement building or advocacy has really happened to push for vasectomies, I would say, as well as condom usage, both. So this is something I think that requires really a huge amount of momentum and advocacy at this point in time. Next. Yeah, I just, if, we could show you a short film. I don't want to paint a very sorry picture that everything is bad in the medical system and that nothing is happening. That's not true. There are islands of success and good practices. So I quickly want to show you a film that presents to you a young unmarried person who's actually come to a public hospital to seek medical termination of pregnancy. IMPRI team, will you share the video, please?
Yes, ma'am, will share.
ही गोळी सकाळ 3 दिवस घ्यायची. चट्टी बाहेर जातो.
पूजा, चलो चलो चलो.
सिर्फ पेशेंट अंदर जाएगा, आप बाहर बैठो.
जा.
क्या नाम है?
पूजा.
क्या प्रॉब्लम है पूजा? क्या प्रॉब्लम है पूजा?
पीरियड डिले हुआ है.
कितने दिन का डिले है? पूजा, कितने दिन का डिले है? ये तुम कुछ बोलोगी भी, बाकी पेशेंट्स भी है।
Can I come in?
या
अरे वाह डॉक्टर, काफी फ्रेश लग रहे हो। आपका फोन बज रहा है।
हाँ, एक्चुअली मैं पेशेंट के साथ होता हूँ तो फोन आंसर नहीं करता, पर MS सर का कॉल है। क्या सर? हाँ सॉरी, मैं पेशेंट के साथ था।
पानी चाहिए? और चाहिए? तुम्हारा नाम क्या है?
पूजा।
पूरा नाम?
पूजा शिंदे।
उम्र?
21।
देखो पूजा, डरो मत, बिना हिचकिचाहट बोलो, नहीं तो हम तुम्हारी हेल्प कैसे कर पाएंगे। तुम्हारी उम्र क्या है?
19।
अकेली आई हो?
मैं वो बिल्डिंग फ्रेंड के साथ आई हूँ।
बताओ यहाँ पर हॉस्पिटल में क्यों आई हो?
पीरियड डिले हुआ था।
घर पर किसी को पता है?
नहीं, घर पर किसी को नहीं पता।
कितने दिन का डिले है?
26 दिन का।
ओके।
और घर पे टेस्ट भी किया था।
प्रेगनेंसी टेस्ट? डोंट वरी, एवरीथिंग विल बी ऑल राइट। हम तुम्हें इस हॉस्पिटल में सारी हेल्प करेंगे, लेकिन अगर तुम डॉक्टर को डिटेल्स ही नहीं बताओगी तो फिर हम तुम्हें सही ट्रीटमेंट कैसे दे पाएंगे। चलो आंसू पोछो।
सॉरी मैडम, आप मुझसे कुछ कहना चाहते थे?
हाँ डॉक्टर। पूजा, आप वहाँ जाकर डॉक्टर का वेट करो। सिस्टर,
इस उम्र में बाहर जाके सब कुछ कर लेती है, लेकिन हॉस्पिटल में आके कुछ नहीं बोलेगी। नो कोऑपरेशन एट ऑल।
ऐसा नहीं है डॉक्टर रोहित, ऐसे यंग लड़कियों को रिप्रोडक्टिव और सेक्सुअल हेल्थ सर्विसेज की ज़रूरत होती है।
हाँ, लेकिन अगर पेशेंट डॉक्टर को कुछ बताएंगे ही नहीं तो डॉक्टर हेल्प कैसे करेंगे?
थोड़ा इमोशनल सपोर्ट देना पड़ता है, थोड़ा रैपो बिल्डअप करना पड़ेगा।
क्या मैडम, इतने सारे पेशेंट्स की भीड़ में रैपो कैसे बिल्ड करेंगे?
मैं मानती हूँ डॉक्टर रोहित कि पेशेंट्स बहुत होते हैं, लेकिन अगर हम उन्हें कॉन्फिडेंस दें तो वो बिना हिचकिचाहट के हमें सब कुछ बता देंगे और इसमें ज़्यादा समय भी नहीं लगेगा। मैंने देखा है कि जब हम मेडिकल सपोर्ट के साथ साथ अगर पेशेंट्स को इमोशनल सपोर्ट भी देंगे तो काफ़ी फ़र्क पड़ता है पेशेंट्स में। 25 साल से मैं इस हॉस्पिटल में काम कर रही हूँ और मैंने ये बात ऑब्जर्व की है। वैसे पूजा ने मुझे सारी डिटेल्स बता दी हैं, आपसे भी बात करने के लिए बिल्कुल रेडी है।
सब कुछ बता दिया?
बिल्कुल।
कैसे?
डॉक्टर रोहित, वी ऑल हैव बीन यंग वंस, और जब हम यंग होते हैं तो ऐसे सिचुएशन से गुजरते हैं, और जब ऐसा कुछ होता है तो डर तो लगता ही है। वैसे पूजा ने काफ़ी हिम्मत दिखाई है ना?
वो तो है।
चलिए डॉक्टर रोहित, आपकी पेशेंट आपका इंतजार कर रही है। अच्छा, पिछले हफ्ते दिलासा का वर्कशॉप हुआ, वो आपने अटेंड नहीं किया राइट?
शॉप? हाँ, मैं
उसके हर वर्कशॉप में मैंने कुछ ना कुछ जरूर सीखा है। अब कुछ ही दिनों में उनका अगला वर्कशॉप होने वाला है, सो साथ में चलते हैं।
जरूर।
Good afternoon, everybody. Hello, friends. I am here to talk about comprehensive healthcare response to the survivors of violence. Now, what is Dilasa? Dilasa means reassurance. Emotional support is the first thing what we have to give her. Whatever she is saying, we are listening to her, she is going to open up. Nowadays, we are receiving so many young girls and adolescents who seek information about sexual and reproductive health services. What do you think? How can we help them? Can anybody answer this? Yeah.
I think we should recognize that they have faced a big challenge in coming to us, and we should provide them with medical treatment but also psychosocial support.
This is absolutely right. Adolescents are facing so much of problem of stigmatization of unwed mothers, and if we also don't give them any help, then they have no place to go. Then to go to quacks and do some different types of abortions, and which again have so many complications. When they come to us for the first time, we have to assure them and give them the help needed.
Dilasa is a very ambitious project of Mumbai Mahanagarpalika with the support from National Health Mission. It addresses the issues of domestic violence and sexual abuse in children and females. And these kind of centers are located into health environment, or we can say hospital based. Right to healthcare is a very quintessential part of public health department, and we always work towards that. In case of females, in case of unmarried women, lot of health issues come up. Sometimes issues of medical termination or abortion. So we need to understand those issues, their right to health during such crisis. Dilasa Centers has a special and very characteristic role to play to the women in the reproductive age group or to adolescent girls. We recognize the hardship faced by women and girls accessing healthcare services. Hence, the skilling or sensitization of healthcare providers and to develop a sensitive communication skill is our motto at basically at the Dilasa and in general in all the health facilities.
Yeah, team, you can just stop it because I can see that we are going overboard with time. So you may want to just share it with everybody, the other stuff here.
Thank you.
You can just copy paste the link in the chat in the chat box. Sangeeta.
I'll do that. I'll do that. Yeah, so
Thank-
thank you very much.
Thank you so much, Dr. Sangeeta Rege ji, for your speech and for your keynote address, particularly the insights, the case studies, and the video that you shared with us really made very important reflections spark among our audience. So thank you so much, ma'am, for your time and wisdom. The floor is now open for questions from the audience. You can raise your hands or type in the Q&A box. Meanwhile, I request Professor Vibhuti Patel ji to add her comments about the session.
I think I have nothing else to add because she has taken up all the issues regarding reproductive autonomy, reproductive freedom, bodily integrity, and dignity of women. Thank you, Sangeeta.
Thank you, ma'am. Now I request Dr. Manorama Bakshi, ma'am, if you have any comments and suggestions to add about the session.
Yeah, the session was very nice, but I would like to put one or two comments here because the film was very nice and I want the audience to know what the film actually spoke about, which is very important, like when it comes to the counseling. In family planning, we call RMNCHA, the reproductive 5 components that any government facility or any facilitator at a government facility had to follow. One was having the contraceptives, which the doctor spoke about, having the contraceptives, oral pills, DIMPA, injectables, condoms, IUCD, having the option of female sterilization, male sterilization. So I want to put it here, when we talk about the male vasectomy, it is even below 1% as per NFHS 5. So I wanted to bring it here, number one. Number second, I wanted to bring it here, like when we talk about, we saw the film, we call all the counselors and family planning, we used to say that gather. The short form of this film, suppose you are tomorrow going in any field, gather means greet. Greet the person when they come to your, family planning center. Second is A. A is ask. When you saw how that nurse was asking her questions, kahan se aayi ho, kya karte ho? GA. T means tell. Tell her the options, which our doctor spoke about, giving her all the basket of choices, and whatever best suits her, she can pick up that component. That is telling her. H is helping her out, providing those kind of services. And E means ultimately like how we are impacting her and talking to her. And R is about return. Suppose, for example, we gave her any method or anything, when is she further going to sort of come or replenish her, if it is OCP or if it is any other kind of things, or we can make her so return. asking her to come back. So these are the 5 components of gather. E means basically to explain the whole thing. If we are giving you what are the repercussions, why are you, what is condom, because of the certain kind of even though because of the time's paucity I won't be able to talk much into it, but recent research was in South Africa wherein it was found out most of the hormonal non-barrier contraceptives, when we talk about the pills and those kind of things against the unwanted pregnancies, oral contraceptive pills were seen to increase the risk of infection, especially HPV and cervical. That is about couple of years. So when we offer the person with pros and cons, as doctor also mentioned about, it is let them choose, but at the same time we have to mention. So that is why in certain parts of Africa now it is imperative that they have introduced that if a person is into high risk group, to offer them both. One is barrier method, that is condoms and other things. And second is non-barrier method, offering them pills. So that the person, one is unwanted pregnancy, second is about through condoms and all that, so that we can avoid the STD and we can avoid the HIV-like infection. Because only condom is something which will be a barrier against those kind of, diseases. Thank you.
Thank you so much, ma'am. There's a question by Celia G. If you could please unmute and go ahead. Okay, I'll just read out the question, ma'am. So the question is, I wonder if those issues are all over India or if they are concentrated on particular states.
I mean, I would definitely say that these are issues across India. In fact, I just, for example, wanted to put, which I did put in the chat box, if you take a look at the urban-rural divide. So more than particular states, there is a slight difference in the urban-rural areas as far as the contraceptive uptake is concerned. But I would consider that Maharashtra or Karnataka as some of the most developed states. If their indicators are poor, it's only kind of telling what would be the situation in several other places. And of course, like I said, that it's not only to do with perspective, but it's also about availability of, trained medical providers. So that's the other concern.
Thank you so much, ma'am. Are there any other questions from the audience member? Seeing none and looking at the time constraints, we will be concluding the session now. So thank you so much, Sangeeta ma'am, for taking out the time to attend the session today and for enlightening us with your perspectives and insights. We're truly honored to have had the opportunity to learn from you and are seriously really inspired by your commitment to promoting these reproductive rights for all the women. Thank you so much, ma'am, and we really look forward to welcoming you to our future events.
Thank you so much. Thank you. Have a good evening. Bye.
Thank you, ma'am. Now, I'm privileged to call upon Dr. Amar Jesani ji to expand our knowledge on the topic Abortion and Conscientious Objection, Ethics, Law, and Reproductive Rights of Women. We welcome you, sir.
You're able to see it?
Yes, sir.
Okay, great. So good evening to everybody. Well, my topic is very focused. I'm not going to talk about abortion in detail, and I'm happy that Sangeeta covered part of what is happening in the field of abortion. So all of you know about it, that we have a law, there is some liberalization, and recently we have made it more liberal by extending abortion up to 24 weeks of gestation. And then later on also on the court orders, we have, provided abortion even up to 28, 29 weeks. So this is a thing that is there in place. However, at the same time, abortion, as I think somebody wrote in the chat box saying that there's a lot of stigma, there's a lot of problem, religious problem and moral problem. So this is what we are going to discuss here. A large number of, a lot of material on abortion and ethics we have published in Indian Journal of Medical Ethics. So some of you who are academically oriented, they can access it. This is an open access journal published for last 31 years, and you may benefit by looking at the literature. We must have published a few dozen articles on the subject, so, and a lot of debate too. What I'm going to do is cover mainly 4 points. The fifth one, if we get time. The 4 is to look at a history and how abortion is entangled with religion. Then come to the heart of the issue is what are the different ethical positions on abortion, and then go into 2 related issues: is conscientious objection as well as conscious, for providing the services. And then, if we have time, we'll talk whether the abortion is problem is increasing resistance against it or decreasing. And you all know, recently, a few months back, America has made a retreat from the liberalized abortion to more restrictive area by prohibiting it, simply because the Supreme Court is now having a lot of conservative judges there. So this is going to be an interesting thing to watch, and its impact also in India, which is of having a more liberalized regime on abortion. So let me start with the first thing: is looking at religion and medicine, how it is entangled with the abortion, and why abortion was criminalized for such a long time in history, and it's only in last 150 years that you find the liberalization coming up. So let us first look at the basic thing. What is reproduction? See, reproduction is normal biology. All of you know about it. And so reproductive health should be looked at as a normal biological issue. And that's how contraceptions, as well as childbirth, and all of them are primarily a biological issue. They're simple, physiology where you're looking things happening. It's not pathologized. Pathology comes only when there is a complication and infections and those kind of stuff, or some kind of degeneration, growth, cancerous, and that kind of thing. So predominant users of the reproductive health services are healthy men and women, particularly women. And despite that, you will find that reproduction is always, surrounded by so many problems and issues. And that is simply because there is always an elephant in the room. Whether, a woman goes to get a contraception, then because she wants to regulate her fertility, the issue comes, who should be using contraception, right? From that it starts. Why only women should be using, why not the man? From that to what kind of contraceptive. And if you come to abortion, it is even worse. Reason is that this is not a free doctor-patient relationship here. There is a third party, which is a societal morality, which decides, what is right and wrong for the couple, for the individual here. And as a consequence, it keeps interfering. So that elephant that we need to bring out in the open and try to understand. And because of that, suddenly you'll find that instead of having a focus on the woman and her welfare, the issues start revolving around something else. Do we have more population? That's what the question will be asked, rather than saying, does the woman need certain kind of contraceptive or the regulating her fertility? So I think those kind of the social issues start dominating, moral issues start dominating. Does the family give permission? Family comes in, right? And all kind of things you'll find. And in abortion, they will start asking, oh, isn't the fetus also a human being? How can you kill? And so every abortion is nothing but feticide, So it's a criminal. That's how the criminalization takes place. So all kind of things you will find coming up when you are talking about reproductive health. So it's very, very intertwined with social and moral issues. I think I saw that posting in the chat saying that, yeah, most of the religion are opposed. Yes, not most, all. I'm still looking for a religion which is saying that, yes, woman has a right to abortion. So it is Christianity, Judaism, Islam, Hinduism. You just have a look. I just given you, I'm not going to read it because I want to save time and you are already running late. But in all of them, either they are fully opposed or they say that, well, we are opposed up to a certain time, in a certain time of conception. And that depends upon if they have a concept of soul, that when does the fetus get soul? Normally, it is 40 days to something like, 90 days, in between that. So depending upon those understanding, they said, well, abortion should never be carried out. You know that till 19th century, the colonialism was very, very strong. Imperialist power was controlling most of the developing countries, where the non-Christian people used to live. So the Christianity was one of the biggest, and particularly Catholics, were the biggest dominating force. And what I read from feminist literature on Catholics, there is an organization called Catholics for Free Choice in US, and I think they have published quite a lot of the stuff and critique the Catholics in religion from the gender perspective in a big way. And they say that, well, till later part of 19th century, 1869, they had a concept of ensoulment up to say 90 days. And till then abortion was tolerated. It was not acceptable, but tolerated. You can go and confess about it and do some, some kind of things, and then you are given freedom. But then in 1869, the Pope made it sin, and sin so big as to excommunicate a person. So it became a real problem. So that 19th century was very, very critical when the states were being formed, and if they pass a law, it can really criminalize the abortion. And this has an ally. Ally was medical profession. The American Medical Association, even before the Pope did it, passed a resolution saying that, no, we are not going to support the abortion. And both of them came together. So if you look at traditional, ethics codes, whether it is Hippocratic Oath or even Charaka, both of them you will find opposed to abortion, saying that no, abortion should not be carried out by the doctor. It's in certain circumstances, for saving woman's life, they may agree, but not beyond it. So that is the only small window available. Otherwise, absolutely not. Some are completely opposite, right? Modern codes, yes, they are liberal, but liberal to the extent by saying that, well, you should, that is the international code, the Geneva, Code of Medical Ethics, that which says that, well, you should do according to the law in your country. That means you are not prohibited, but you can carry out if the law is in your favor. And mind well, most of the early abortionists in the history were women. They were traditional practitioners. The modern medicine as a professional medicine emerges only in 18th and 19th century and gets solidified in 19th century. You must have heard about witch hunting and all. Those were the women who were providers of the healthcare for the women, childbirth, abortion, and other things. And those were gradually, hounded out. And the new midwives gone, and the new specialty, the obstetric and gynecology, starts coming up from the later part of 19th century. So that was where the medical profession exerted its power, along with the religion, and passed laws in most of the developed countries who were imperialist power and controlling the rest of the world to criminalize the abortion. So from later part of 19th century to 1970, 71, 69 to 71, for one full century, in nations, abortion was criminalized. So it's not just in India, British did it, but everywhere it was done, whether it is USA, Europe, everywhere you'll find this similar kind of pattern. What happens in India? Till 71, India also continues with the same system. Indian Penal Code says that, well, you cannot do, and it is criminalized. It was only in 1964, I mean, late 50s, we started family planning program. And that's where the need for abortion was felt. In India, there was never a strong women's movement either in support for the liberalization of abortion, and there was also not strong religious movement saying that keep abortion criminalized. So it was a very amorphous situation at the political level there, and so most of the initiatives comes from above, the policymakers. And they were worried about how to control population. And since family planning program was started, they needed abortion as a backup when the contraceptives failed. It's not abortion is not advocated so much as a contraceptive in itself, but as a backup to the contraceptive. Some people may use it as contraceptive, but that is a major health problem. And most of the time, the officially it is for the backup to the contraceptive failure. And second one was that number of abortion, millions of abortion, just as they are taking place now, were taking place at that time too. And most of them were taking place in a very unsafe condition. And so static abortion was a major problem. You will find several studies by the ICMR and other organizations showing that India's high maternal mortality rate had a big contribution, something like 15 to 20% contribution coming from abortion, septic abortion. Women were dying, right, because of the unsafe abortion. And both of them came, that means demographic consideration and the medical considerations came together to liberalize it. And the liberalization was to provide the authorization to the medical profession to undertake medical termination in the certain condition. The entire law is not worded as a Women's Right to Abortion Act. Just keep that in mind. It is worded as a permission to the medical profession to undertake abortions under certain conditions. That means woman can't go and say that I want abortion just like that. She has to give explanation, which should be as a part of the law and whatever the things which they allow. Most of the time you say that, well, I'll be psychologically disturbed and that kind of stuff, or my social or economic condition does not allow me to support child at the moment, and doctor will accept. But a doctor can also refuse accept condition, what we are explaining. That means if medical profession becomes conservative, anti-abortion, then you have a major problem even with the liberal law that we have. So, limitation of it is that it says that you have a right to go and access it. Only government will provide you free of charge, but government is not everywhere. So you don't have a right to access abortion wherever you are located. You have to find a right place to go, government. So it's not a socio-economic right. That even if I go to say a nearest private provider, the government will reimburse it. No, that is not part of it. It's a civil and political right of medical termination that is provided. Now let me come to the core of the presentation. What are the different positions? I have just given here one reference from where I have taken this information. That is Bonnie Staybock's contribution to bioethics briefing in the Hastings Center, which is one of the topmost bioethics center in New York, in USA. So there are three types of positions, and we'll go quickly to three. The conservative position, which is called pro-life. liberal position that is pro-choice, and a little extension of it, a feminist position which says that, well, it is reproductive rights, and the moderate, which is the compromise. What are the conservatives, like the way American, Supreme Court argued, are saying? The early conservatives were religious people. They said that, well, you cannot interfere in what is God's will. Okay. And they were essentialists in that term, and said that any kind of human intervention there is not allowed. And because it is the life is God's life, that's why it's not only abortion, but even say suicide, even assisted suicide or assisted death, like what you call euthanasia. All of them, they are opposed to it, saying that life belongs to God. You cannot take it. That means my body is not my body, it is God's body. And till in our country, suicide was illegal. The government used to claim that your body is mine. You cannot kill your body. If you try to kill your body and survive, you'll be prosecuted. Right? Same thing here. That is how the conservative position was. And but out of that, there is also a rational position that conservatives are taking, and it's saying that, well, the fetus has a life. Fetus is human being, and doing abortion is killing a human life, and so we cannot do it. What is the liberal position, which is called, pro-choice? Liberal position says that yes, fetus is human being, or a potential human being. It's a life, no doubt. However, but is the fetus having a full moral right as a person? The person is recognized in the law only when the person is born. When person is fetus, it is not. Because we also have a lot of spontaneous abortion without any intervention of medicine or any other person. These abortions are spontaneous murders. That's what the question they will ask. And if you extend it to the feminist argument, they will say, well, who takes privilege when there is a problem? The woman who is alive of you, who is adult, who has a mind to decide what is best for her, is that person takes privilege, or the fetus that the woman is having? And who are you to tell her what she should be doing with that fetus? I think this is a conflict which is there. And it has direct connection to what they call patriarchy, the position of women in the society. Most of the time, are the women able to decide that whether to become pregnant or not? How is the sexual act and sexuality play out in day-to-day life? To what extent they have real autonomy to protect themselves from the advances of the man, and even convince the man that he should be following the kind of contraception that is required. Given all this thing, that is a liberal position and the feminist position of reproductive rights are advanced by the pro-choice groups. What is the midpoint? That is moderate point. Most of the laws are moderate laws. I think not most, all of them which are there. And what is the midpoint they try to find? They try to balance between pro-life and pro-choice. They said, okay, yes, we will accept the pro-life argument by saying, but we will allow you it only to the extent that there is a scientifically possibility of viability of the fetus if it is born today. Right? So you have to find out at up to what gestation period, when the fetus comes out, it will survive. Is it 20 weeks, 24 weeks, 28 weeks? So this is one. On the other hand, they say pro-choice people that, okay, yeah, up to that time, fetus cannot survive on its own. And so let the woman have choice. So this is some kind of what I would call balancing act. And it hinges on the conception of fetal viability. But at the same time, it has a strong conservative element, is that the fetus is all the time in the discussion and not the woman. Is the fetus viable? what was the date of conception and what is now? Will the fetus survive when it comes out? No, those are the things. Is the fetus having deformity? All those things. And the secondary thing is about that if abortion is carried out, will her health get affected? And the third thing, which is the last point that they talk about, is that what are the wishes of this woman who has come for abortion? So her autonomy is put relegated at the end. I think but that is how the moderate position is. And if you read all the Supreme Court judgments and some of the good judgments, and then retreat again, good judgment, and sometimes they have passed the judgment and withdraw the judgment. The orders have been withdrawn. All these things, when you read them, you will find that it has a continuous conflict to area. So this position is always a moderate position, is always unstable. In the US, when 1971 Supreme Court made it liberal, it was always unstable, because when the conservative became very powerful, they push back. Tomorrow, if the liberal become powerful, they'll push back the conservative position. So this is what happens in the moderate standpoint, and the world or the society is not able to take a strong moral position in support of the woman. There are other things that happen along this. I'm not going to talk about all of them. You know about I already told you that it's a civil and political right, but it is not social and economic right to have abortion. There is also issue of disability becoming one of the major ground, and that creating a lot of stigma against disabled, and use of abortion as a population control. There are many other issues like sex selective abortion. There's also a whole debate about what we call ectogenesis, where the fetus is grown in the artificial womb, and they say that once you master it, you may have abortion without fetal death. That means you can transfer the fetus from woman's womb to the artificial womb, and that way, the conservative position can be. But that is how thing. Neurosciences also keep coming out with the findings saying that the fetus may be perhaps very early in this stage feeling pain, and if that is so, the viability period should be reduced and not it should be more, as we have tried to do, from 20 to 24 weeks. And then there is a last thing, is the conscientious objections and the provision, which I will deal with, because that's where how doctors behave comes out. So let us go to the right to conscientious objection. Here also, what is conscious, that you have certain moral position, and if you are asked to do something differently from it, you feel that you are morally injured. Your conscience is violated. That somebody who is opposed to abortion on moral ground, and if law says that, well, as a doctor, you will have to perform abortion, then the doctor said, no, I'm not going to perform. I should have a right to objection and recuse from it. That is how the whole concept came here. This concept is not only for abortion, it is also used for, say, doctors' unwillingness to participate in euthanasia. It's another one, okay. That's how you'll find that deeply moral beliefs of the doctor, which are social beliefs or religious beliefs, they supersede the morality and ethics of the healthcare. The morality and ethics of the healthcare says that yes, they should be providing abortion, but there are many who still cling to that on social beliefs, and they would not like to do it. So that's where conscientious objection comes. And there are three positions on it. Conservative says that, well, they should have an absolute right to object if they don't agree, and they should recuse. Liberals say nothing doing. You should not have a right. Why? Because you join medical profession knowing fully well that medical profession does the abortion. Now you can't turn around and say no. And when you say no, what happens? You are denying somebody care which she comes and wants it. It's a client of the medical care. And so you should not have a right. Once you become doctor, then you should accept the healthcare ethic. The moderate position, which is a legally made position, says that, well, you can recuse provided there is somebody else, another doctor is available to do it. In large hospital, it may be possible, but it may not be possible in a rural area where you are the only doctor who knows how to do it, or you only gynecologist available, only trained person available. So that way, if there is a more and more recusal, then the woman's access to abortion gets curtailed. What happens if there is a, and this conscientious objection comes up in those settings where abortion is liberal, where it is provided and provided to the doctor. So here is another scenario. What happens when the abortion is illegal? Right? What is the doctor's conscience here? What is happening in USA today? Criminalize abortion. Supreme Court says you can't do it. But if doctors who believe that it should be provided to the women, do they have same right that conservative demand as a conscientious objection? Do they have same right to have conscientious provision? No. That is where they will say no. A very important and sensitive issue, especially in those countries, and there are a large number of countries where abortion is criminalized and restricted. And they say that, well, a negative right of denying care is not superior to positive right, where you are proactively helping somebody who needs something. And so conscientious provision should be a bigger ethical concern, a support than objection. So far in history of bioethics, you will find that most of the time debate is about objection. There's very little debate about being proactive and providing it. And so even when it is illegal, does your morality and ethics of the medicine say that you should violate law? And the issue of violating law is very important, because we wouldn't have become liberated as a country if we had not violated British law of enslaving us, right? We said, no, we are going to fight against you and get liberation. We'll not accept your law. Same way, Section 377 for the gay people and all. How did it happen? That's simply because, morality and science say that what you are talking is wrong. The law is wrong. The law is there, but its ethical basis is wrong, and that's how it needs to be opposed. So this is another area of debate in bioethics literature coming up. So this is again same. I'm just using one quote which says that the negative thing is not bigger than the positive, providing it, right? And if you have more and more objection, it is going to lead to more stigma and of the abortion provider. So I don't go, because time is very important. So this is the last slide, is to reflect. Is support to abortion increasing worldwide, or it's declining? Law is definitely becoming tighter. In India, it is becoming slightly, liberal, but in many other countries, it is becoming tighter. So it is easy to say, well, in USA, it is going down. But what about the elites of the societies, those who are opinion makers? And are they changing their opinion? And this is a study, a similar kind of study looking at opinion makers, and they were trying to find out. On the right side, the dark blue, they show the percentage of people who are striving to make abortion illegal. And you find that the third country in the bottom is India, where 36% of the people say that abortion should be made illegal. And this is this was when I saw this report, it was a revelation. This is not a kind of opinion survey of the common people. This is a opinion survey of, as I said, the elites of the society. And there is definitely more religiosity in our society at the moment. And as I said, that every religion, whether it's Hinduism, Islam, Christianity, all of them are opposed to abortion. So something that we got on platter, through because of the population control concern as well as maternal health concern, is suddenly we find that an opinion is turning gradually, but it is turning. And so we have to be very, very careful. And I think women's movement will have to be very, very careful on that, not including abortion right as one of the plank of their program may cost us simply because there may be, some judges or some lawmakers who really curtail the right that women have now. And more importantly, in a context where the whole pressure of population control has reduced considerably, right? The fertility is going down. And we are now, for the first time, we are talking about, having good population is an asset rather than having less population. This debate was never there earlier, in my younger days. Why it is coming up? Simply because it's no longer that pressure. It's there, but it's not as much as it was earlier. And so the commitment of the society to the right to abortion is going to get affected in that. So keep that in mind. And that's how, in order to preserve that right, I think we'll require more consistent work on the subject. So thank you very much. If you have any question, I'm available here. I think I've taken 25 minutes and hopefully we'll have 5 to 10 minutes to interact.
Thank you so much, sir. We're truly grateful for your time and wisdom. Your insights truly expanded our knowledge about the subject matter, but it also made us understand the complexities of abortion. So thank you so much, sir. The floor is now open for questions from the audience. You can raise your hands or type in the Q&A box. Meanwhile, I request our chair of the program, Professor Vibhuti Patel ma'am, to add her comments about the session.
Thank you, Dr. Amar Jesani, for bringing out a very important concern of the women's movement, especially the safe and affordable abortion on demand by women is a human right. And when safe and legal access to abortion is restricted, women are forced to resort to less safe methods, as we are seeing in the Bakshi now, even this day in city of Mumbai. Too often, what we see is that the damaging and disastrous results for women, and also not only social stigma, but the bodily harm and the backdoor abortions are still prevalent in our country, and poverty, marginalization, and also the stigmatization and the predicament on the lives of young girls, I think we need to keep into consideration. And I think now also it is such an important issue for the women's movement, even when we have a legalized abortion.
Thank you so much, ma'am. Now I request our co-chair of the event, Dr. Manorama Bakshi ma'am, to add her comments about the session.
I think Dr. Jesani's presentation was very insightful, very much knowledgeable. The only thing I would like to speak here is, since I come from the background of RM and CHA, I would like to raise this point here. Unsafe abortions are currently third leading cause of maternal mortality. Almost every day, 8 women die because of unsafe abortion. So it is something like we also need to, along with other things, we need to look into that women get safe abortions, and we either through qualified practitioners. That is one thing I would like to raise. And second thing I would like to raise, even though MTP Act needs a bit of, even though it was reformed in 2022, but still nothing much has been spoken about comprehensively about the economic aspect. It needs some kind of it should also include the economic burden a woman has to undergo in raising a child, which even though we talk about if it is a rape or if it is a woman may undergo the abortion of the fetal is not well developed or those kind, under those conditions a doctor can prescribe, which Dr. Jesani said, it is doctor to decide if the woman is like pregnant, or if she has almost like after 12 weeks, one doctor's advice, 12 to 20, again, one doctor's advice, 20 to 24, two doctors' advice needs to be there. But then we also need to look into those aspects as well. So I think that these are some of the things. And again, like PCP and DT Act, like the main purpose was to ban the sex selection, but somehow like with abortion and other things coming in, we need to have, those kind of needs to be addressed as well also. As Dr. Jesani spoke about the US in United States, about criminalization of the abortions, I will share my own experience of working with the Ministry of Health in 2013. The states which were funded with US aid internally had called a reproductive health FP meeting, wherein they had said, we used to call it CAC, comprehensive abortion care. And they used to say there's no need to fill in, like we had the SOP wherein we would be writing 5 into 5 metrics whether comprehensive abortion care is happening, at which weeks, XYZs and all that. But they said that you can ignore it. इस part को जरूरत नहीं है fill करने का. This is, I am talking about USAID supported like states wherein the district lead monitors and supervisors were being told, इसको बढ़ने की जरूरत नहीं है. That kind of a thing. So these things are happening, and there are countries like who thrust it, even though they are in different countries, but just because they are sort of supporting certain health programs, we have to look into those aspects also. And one more thing I would like to emphasize here, as gatekeepers of reproductive health, I think that we need to look into the, quality care of women seeking abortion services. And along with that, we also need to involve ASHAs and community mobilizers, how they can look into and see like social stigma around abortion and address those kind of, healthcare provider is very, very much essential, like, because they have the access to families and women very closely. Thank you.
Thank you so much, ma'am.
Oh, thanks a lot for all the comments. And let me say a few things. And there are also a couple of questions on the question answer box. So I'll take up just all of them. Well, it's I was not talking about abortion and its access and those areas, but yes, they are very, very important. They are also ethical issues. I raised that I think there is no socio-economic right to abortion. Actually, there is no right to abortion. What is there is that there is a liberalization of the way the medical profession can provide abortion. And if medical professional is not providing abortion, then it is illegal per se, okay? And it is done on the basis of what is called the issue of safety, the having a safe abortion. And it's also, if you read the Abortion Act, it is also one of the acts in India in health, which prescribes, what is the standard of a place where the abortion will be conducted. We don't have standards for our nursing home and hospitals, right? We have a Clinical Establishment Act, which is floundering. It's not able to establish those standards and go and actually inspect hospital and say that, well, you are not, conforming to the standard. You don't have that kind of system in India. And as a consequence, they do whatever they like. But in MTP Act, that is all prescribed. And that itself, because I think it was done in 1971 when there was no medical abortion. It was only surgical. And when, because of the support of the family planning program, massive money coming in the support of family planning program from abroad, the cheap abortion services became a big money spinner. I studied the medicine in 1970s, and people who came out at the time, as an obstetric and gynecologist, and they had no job in the government, so they had to start on their own. So they become entrepreneur. They started small clinic and all, and the abortion was the bread and butter, the money spinner, which was cheaper. You provide cheap service, but you have a big mass of women coming there, and that was a big demand for it, right? And so they made money on it. But today there is a conservatism in the doctors, not only because they are becoming more religious, but also because of the availability of medical abortion, where the woman can take those pills and early abortions, which were going for surgical care, are no longer available. And that's how you'll find that more and more doctors will say, oh, in order to meet the national need, we put aside our ethics, but now we don't want to do it, right? And you'll find many, many doctors that I have known and saying that, well, we don't want to do abortion now. So there is a turning happening, and that might create problem for the women's right to abortion. You describe about USAID and American stuff and all, but you know very well that it depends upon who is the president of US. I remember being in the University of San Francisco, California, or in San Francisco, and California in San Francisco, and I was making a presentation on reproductive health in India. And then I asked them a question, at that time was a conservative President Bush. So I said that, well, at the moment, even USAID doesn't give money in India for abortion. So if I want to continue with the abortion services and with the money from USAID, I have to use deception and get the money. And that's what many are doing here in that. I say that we are doing good reproductive health of the women. So you started talking about adolescent health, this, that, and all. And you take money from that and also subsidize your abortion care in the NGO sector. So I asked them, what are you doing in San Francisco reproductive health in your obstetric and gynecological department? And they were very straightforward. We also deceive them. Right? So this is how it is, you see. So this politics interfering in the right to abortion is everywhere, right? The last thing is what you asked Dr. Bakshi is about the kind of position that Supreme Court is taking. First of all, I don't know why after 24 weeks, most of the cases have to go to Supreme Court. I mean, how many cases can actually go to Supreme Court? Right? We don't. I mean, I have never exercised Supreme Court. I'm 70 years old, right? So, but do people have money and have a reach to go there? You have to have a offer can be done at the low. Secondly, by the medical board in the minds of the judges, saying that, well, if you are telling me I may have to kill the fetus who is having beating heart. Now, beating heart starts at the age, 15 weeks. Right? So you never complained when you were doing at 20, 24, but you are now suddenly telling the judge that, well, I will have to first stop the heart. So the judge gets, no, I am not going to do it. And withdraws the order that was passed in favor of the woman. This is what has happened in Supreme Court. And that's how there has to be some strong protocol, totally worked out procedure about how these medical boards are going to function. What are the criteria they are going to use, medical criteria, in order to make a judgment? And they have to be very clear-cut in that. What kind of counseling they will have to prescribe for the woman who wants to undergo it, and her family, if she is minor. All those things will have to be worked out properly. In India, medical profession has not followed the course, Every doctor says my protocol is the best protocol in the world. That is what India is. And that's where I think we have to really intervene and do it. Anyway, there are 3 other questions here and in question answer box, and I'll just quickly respond to them. So one is about reproductive health ethics. When I was talking about, I think I made a mistake. And I perhaps talk only about the reproductive biology. Right. So its concept is not limited to the bodies which can reproduce. Right? It is about reproductive organs of every kind, whether they are as they were or it is change, where the biological transition is taking place. All of them, they include reproductive health. So transgender processes using hormones as well as surgical intervention and all, they're all part of the reproductive health intervention. But I was, got carried away by talk on abortion, so I did not mention it. And I hope you get it that in general, yes, it is also there. All of them you'll find go with the healthy bodies. right? And depending upon what they require, like surgical abortion is an intervention. Same way, the changing of the sex is also an intervention there. The second, that question was from Shefali Kishore. The second question is from Melodic Mayum. Could you say that India has a moderate system? Yes, we are in between. And that's how it keeps coming from both this, under pressure from both the sides. Moderates are always by conservative and the radicals, to shift position. So if the radicals are very strong, then you'll find that it's more liberal. When the conservatives are strong, the moderate position shifts to the moderate side. So this is how it happens. And so moderate position is unstable position, and we are still in that phase. Unless we have a consensus to draft a law which is called sorry, I think I got disconnected. Unless we have a political will to pass a law which is focused on women's right to abortion and not medical termination. You are not bringing medicine there. Although medicine may be required, or medical intervention may be required to make the abortion safer, but the basic law is a right to abortion. If we do that, then you will find there is a much better chance of having a more liberal thing that coming up. So the Melody has another question. If a girl comes when she is 30 weeks pregnant, will she be advised for full-term delivery? What happens to her autonomy and bodily integrity? A very correct question. And that's what I was just responding to Dr. Bakshi's point, that this is what is happening is that they're going up to Supreme Court to get justice. And they're going because they think that their bodily integrity and their autonomy is being violated by not allowing to undergo it, and decision being left to the judges and the doctors. So this elites decide, and not the woman herself. So there's a major problem. And yes, we have to apply our mind and have more advocacy on the subject. Nikita Sharma has said, do you think the MTP is still in amendment? Absolutely. What I'm saying is that Abortion Act, and then have a supplementary things in the medical laws or the laws in regulation of the medical institution, to ensure that when woman exercises that right to go to a hospital or a clinic to get abortion, then doctor is having an ethical obligation to provide the safe one to her as per this basic law, which is her right. Make it a fundamental right of the woman, and see that nobody violates it. But that's easy said than done, because there are too many conflicting moral opinions in the society, and the societies which are becoming more and more religious, there may be erosion of that right rather than expansion of that right. That's what I'm worried about, and I hope I am proved wrong, and I'll be very happy to be wrong there, right? And I'm sure, hopefully, in coming time, all of you who are young will take up this on a larger scale in the country, and see that this right is not eroded for the woman. Thank you very much.
Sir, there is just one last question in the chat box. If I could just.
Still.
Yes, sir.
It is in chat box. Okay, I didn't see the chat box.
Yes, I'll just read it out. It's from Lakshmi Chetri ji, and the question is, are there any initiatives to promote male sterilization?
Oh, was it for me or it was for Sangeeta? Well, I think it's a vasectomy, and there have been certain advances, and no scalpel vasectomy became very popular in certain regions of the country, and some northeast countries have accepted it much better. But this is a patriarchal society, and more men don't want to take responsibility of their own. In addition to that, women are also anxious. You can imagine a woman who becomes pregnant whose husband has undergone vasectomy, and the kind of thing, the anxiety and social problem that she will undergo. That's how, that anxiety drives women to go and have a tubectomy more than fight with the husband to get vasectomy done. Now, unless we change that moral environment, the social environment, and the power structure at the family level, it is going to be, a big challenge. So yes, there should be more and more initiative, make them, responsible, and if or have at least have more research on male sterilization. Why it is not being done? Or male methods. Only one method that you have, which is there for since ages. Nothing new has come as far as the male contraceptive methods are concerned. Why is it so? And now there are so many women in science and medicine, and hope they will assert themselves and change the scenario. And I'm sure there are many men also supporting this idea. Hopefully that will lead to something.
Sir, can I speak here a bit from the field ground? I would like to maybe speak one or two sentences. Between 2013 till 2017, when I was traveling across India, 184 high priority districts, one component was male vasectomy, wherein we spoke to people across, like both at community level and facility levels about this thing. And at that moment, Himachal was really doing good. I don't know what was the reason, but Himachal men were doing, there was a good percentage of men, because across India, it was around 0.2 to 0.3% male vasectomy. However, in Himachal at that moment, it was around 1%. So we were thinking like, what is the reason? What is it that Himachal in... But now the trend has changed over a period of time. Today, when you look at NFHS 5, it is the Maharashtra followed by Chhattisgarh, wherein we see that trend happening, and the male vasectomy has increased on those fronts. So, but however, I would like to say here now, there are so many modern methods, even IUCDs, women can have the spacing for 10 years, and then again, they can have 5 years based on their own choice, what they want. There are so many modern methods also which we can propagate and talk, wherein like one does not necessarily look into that woman of 23, 24, as we had seen in 2013 and all that in Telangana, woman getting done tubectomy at such a young age, and tubectomy is irreversible. Like women would do tubectomy at the age of like do bache ho gaye, tubectomy kiya, and then maybe down the line she would like to have one more child, or she would like to, you never know that husband is not alive or something, or because it is almost irreversible. But somehow like now we have the options. That these are few of the points from my field experience.
Oh, thank you. I see my experience of IUCD, the copper-T in 1980s were very, very bad. And I saw that. And, in the rural India at that time, and I think still it is the same situation. We still have not reached sanitation in the rural area. And so there were a lot of studies in 1980s, late 80s and 90s about the reproductive tract infection among the women. And this copper-T in 1980s, which was a big promotion by the government. And I was doing a study in primary health center and the community health center. I stayed for 9 months there, just doing an ethnographic work. And I saw that women will have it, and after 7 days, they'll get it out. Why? Oh, doctor is happy because target is rich, but woman is uncomfortable because she is suffering from a lot of infection. And this is creating more and more irritation for her. And so the entire thing failed in a very bad way. So IUCD, yes, because when we are talking about urban women, yes, there are a lot of chances and a lot of things available. Then there was a big debate about hormonal contraceptive, Depo-Provera and Net-N and all. There was a lot of fight against it, but at the same time, we all knew that Indian women will not accept them. Reason? Very simple, cultural. It creates havoc with the menstruation. Whether we like it or not, in every Indian household, woman is watched for her menstruation. And it is done in a very, very unspoken, sometimes, unconscious way, but it is there. the other women folk are just looking at her, So all those things so you'll have to look at medical advances along with our culture and what is the place of women there if you want to make it succeed. And that's how why I was saying that making men responsible is also equally important there. Because if you do that, you also weaken the patriarchy in the process by saying that, well, you are not the one who decides the sexual relation. Woman has equal right there. If that is done, it will change quite a stuff. And you'll find that some contraceptives which are not acceptable today, they're suddenly becoming highly acceptable simply because there is a harmony there and where support from both the sides. And so they decide whether it should be man who is using is better for their relationship, a woman using is better for relationship. But we as a program, as a national level, prejudge that woman is the one we are to target, then you are just playing and reinforcing the currently available power relationship and the social understanding as stigma there. That's the problem that I have found, while looking at this kind of stuff. So it's very complex issue. And well, I think those who are here, but if they will be able to do something in coming time. Thank you. Okay, I think this will go on, and there are more people to speak. So I must say clear. Thank you very much.
Thank you so much, sir, for sharing your expertise and wisdom with us. And thank you so much for answering all our questions with so much patience. It has been a privilege to have you as a part of our event, and we eagerly anticipate the opportunity to collaborate with you again in the future. Thank you so much, sir. Now, it is my honor to invite Dr. Sanjida Arora ji to give the keynote address on the topic Preventive Care Addressing RTIs, UTIs, and Cancer Risks. We welcome you, ma'am.
Thank you, IMPRI team. Thank you, Dr. Vibhuti, and thank you, Dr. Bakshi, for giving this opportunity. So today, through this presentation, I would like to speak briefly about the risk factors. I would say the intersectional risk factors that make women vulnerable to RTIs, including UTIs and the cancer. And I will also talk briefly about the gaps in the policy and the programs. Yeah. Okay. My slides are visible?
Yes.
Okay. Yeah.
Yes,
So
ma'am.
I think it's the I'm not able to move the slides. It's getting stuck.
Have you sent it to IMPRI team?
Yeah. Are they visible now?
Yes, they are.
Okay. So just
It's in
to
working mode, you can.
yeah, just to begin with, I would like to highlight a few facts about reproductive tract infection and the cancer among women. So 80 to 90% of the global burden of reproductive tract infection lies with the low middle income countries, and RTIs are prevalent in both men and women. But if you look at the rate, it's more prevalent in the women, and especially within the women, there is also increased vulnerability of the certain groups, like for example, women of reproductive age group, or when we talk about women of who are ever married women. Similarly, if you look at the cancer ranks in the top 3 causes of premature mortality among women. So breast cancer and the cervical cancer are the most, they account for the largest number of cancer that's globally. And it's important to note that both are the preventable diseases, right? And when we compare the burden of cancer among men and the women also have approximately the same burden as men. representing 48% of the new cases and 44% of the death worldwide. The National Cancer Registry Program 2020 of India estimated that 1 in 29 Indian women would develop cancer in their lifetime. But if you look at how many women presents to the healthcare providers at early stages, it's only 1/3 of the women who they go to the healthcare provider for seeking care at early stages of the cancer. And yeah, then let's look at some of the health disparities when we speak about the reproductive tract infections. So the evidence from the literature has highlighted that girls and the women from the low socioeconomic status have low education, are from the low class or are from the rural areas and are young and unmarried are at increased risk of reproductive tract infections and their symptoms. Also, gender-based violence, I think Sangeeta spoke about it, or domestic violence is an important risk factor to the RTIs. Because of the gender-based violence, there is lack of autonomy among the women to say no to the sex or to insist the partner to use any kind of contraceptives. Then I spoke that women present at advanced and incurable stages of the cancer. We must note that WHO recommends that about 70% of the women should be screened for the cervical cancer, whereas the data from the Indian context highlights that it's only 1% of the women who are getting screened for the cervical cancer, despite the fact that pap smear screening is available at the primary health system level, including the community health centers. Yeah. And then women in the rural areas especially are at increased risk of the RTIs. There is evidence from the literature that menstrual practices, lack of access to the safe, clean, hygienic sanitation for urination and defecation put young girls and the women to the increased risk of reproductive tract infections and the symptoms. Further, the social and the gender norms influence the health-seeking behavior. The stigma around, seeking care for reproductive tract infection. Also, normalization of most of the symptoms of the reproductive tract infection like burning or vaginal discharge. All these contribute to the delay in health-seeking behavior. I mentioned that only 1% of women in India are being screened for cervical cancer, despite it's being available at the community health centers. Then within the women also, it's not a homogeneous group. Okay, so there are groups which are at increased risk. For example, adolescents is a neglected population when it comes to the sexual and reproductive health. Though we have adolescent friendly health clinics, but because of the POXO, how many adolescents can walk into get treatment of any STIs? They cannot, because under POXO the consensual sexual relationships are criminalized. Right. Also, when we look at the sex education in the Indian context, although it's in last few years, it's a phenomena that is emerging, but still, there is lack of capacity of the teachers to talk about it in the schools, and also the adolescents, they don't get opportunities to address their myths. Then further, when we look at the married women and, and especially the risk of the HIV, we all know that the National Health Program of the HIV, right from the beginning, has focused on the vulnerable populations like sex workers or, the truck drivers. But recently, there is evidence from the literature that the married women in the monogamous relationship are becoming the face of the epidemic of HIV. Why? Because because there is normalization of husband's extramarital behavior or promiscuous behavior, and there is also a factor of gender-based violence, and these women are getting the infection from the husband, whereas the program is focused only on the vulnerable population. Recently, they have included the pregnant women within the focus of the HIV program. That's also through the vertical transmission to the fetus. So the married women are, the largely invisible as in the context of the HIV programming. And lastly, I would say that the biological factors also contribute to the increased vulnerability. For example, vaginal tears or the abrasions increase the risk of the reproductive tract infection among the women. Whereas when we talk about the cancer, the late in the menopausal age can be a risk factor for the cancer. Yeah, so these are some of the factors, that play an important role when it comes to the vulnerability. So in the next slide, what I have attempted is that I have tried to put together the factors which increase the vulnerability at the different levels. And I'll briefly speak about each of those factors. I'll start with the individual level factors, factors that play an important role at the level of women. Lack of awareness about the symptoms and availability of the services. There are several studies conducted in the rural India about lack of utilization of screening services and education of the women about the symptoms, the early symptoms, and about the awareness that the services are available has been uh, found to be an important contributing factors. Further, we look at the socio-demographic factors like minority groups or location in the rural areas, marital status. When it comes to the unmarried single women, it's very difficult to access any kind of the health services. Then, if you look at the age, again, the adolescent is a vulnerable group. Then migration is an important factor that contribute to the increased risk of reproductive tract infection, delayed treatment, and early recognition of the symptoms. Then domestic violence, as I mentioned earlier, is an important factor that put women on the risk because they lack autonomy. Then perceptions of quality of care is also an important factor. So in many studies in the rural India, the women feel that the care from the formal health facility is discriminatory in nature, is biased in nature, and so whenever they contract such symptoms, for them the informal providers or the traditional healers is no point of access of the treatment. Then we move on to the interpersonal factors like the presence of the social support or awareness of among the family and the friends that it can encourage women to seek early early help from the healthcare providers. Then there are several factors at the health system that contribute to the in the delayed treatment seeking of the women, and most important is sexism in the healthcare system. So a lot of studies have highlighted, and I think Sangeeta also spoke about it, that there are several biases and discriminatory practices among the providers when it comes to the women of the certain marginalized groups or women in general. Uh, when we worked with the medical educators, we found that a lot of time the health complaints of the women are ignored, uh, especially the complaints which are related to the reproductive health. Also, further, there are power dynamics, information asymmetry between the healthcare provider and the patient, which further, deters women to seek any kind of treatment, especially when it comes to the reproductive health. There's lack of capacity among the providers. So we have seen that, and there's evidence from the literature, from a lot of qualitative studies, that the healthcare providers are hesitant to speak to the women about their when it comes to the symptoms related to the reproductive health. They would like to speak to a relative of the women. They perceive that the women lack the capacity to make any decision regarding her health and treatment. Further, women also reported lack of privacy and confidentiality, especially in the government health facility as one of the factors, for not receiving any kind of care. Then I'll speak about socio-cultural factors that play an important role. Like there are gender norms, lack of autonomy for using any kind of contraceptives or decisions. There is stigma associated with the reproductive health complaints. A systematic review from the Indian context of rural and the urban study showed that only about 16 to 55% of the women who were having reproductive tract infections sought any kind of formal treatment, because there is normalization and also there is lack of autonomy regarding whether to seek or not to seek the treatment. And then lastly, I would talk about the policy. So when we look at the policy, there is lack of intersectional responsive policy, right? They consider women as a homogeneous groups. There are no indicators within the policy to measure the progress towards the, what I say, indicate to measure the progress or the indicators towards equity. And then sex education in the schools is lacking. There are targeted interventions. I gave the examples of the HIV program where only the vulnerable populations are targeted, whereas the cultural context that makes a certain group vulnerable is not taken into consideration. Then when we look at the cancer, the patriarchy dominates the cancer research. What will be researched, who will research this, the patriarchy also dominates that. Just to give you an example, breast cancer is the most common cancer factor contributing to the cancer related mortality globally. Despite this, the only available information about its risk factors available is biological factors and the genetic factors, which are largely non-modifiable. There is lack of research on what are the environmental and the occupational factors that can contribute to the breast cancer, right? So this is just to give an example that the patriarchy also dominates the cancer research, and there is lack of evidence available on the women bodies or the risk factors other than the genetic and the biological factors. Then there is a lack of life course approach to the women's health, where the majority of the focus is on as Sangeeta also mentioned, the maternal health and the family planning, right? And in last few years only the focus has come on addressing the reproductive tract infections or the STIs among the women. And within that also the policy doesn't look at the the vulnerabilities of certain groups among the women. Yeah. So just to highlight that what can be done to address the risk factors, I think the way forward is intersectional feminist approach. We need a shift from blaming women to valuing women in their diversities. Okay, we always say that the women present to the healthcare provider very late, or it's a neglected cancer. So what we need is a intersectional feminist approach where we value the pluralistic experiences of the women. Okay, how this approach differs from the social determinants is that we recognize that there are various factors which are at play, like for example age, religion, or the rural context, which will which will impact the experience of the women in seeking the care. Yeah, recognize the plurality of women's experience and multiple intersectional dimensions of the inequalities, which I just mentioned that there can be various factors at play. Then the need of the hour is availability of disaggregated data. We need disaggregated data on within the programs to say that if these are the gender inequities, then we need those those indicators specific to the specific to measure the progress towards those inequities. Like for example, what's the screening rate among the rural women or the urban women? These kind of disaggregated data is required. Then research on the risk factors for the women. I just mentioned that the cancer research is dominated by patriarchy, and we really need to look at the factors that put women to the increased risk other than the biological and the genetic factors. Then medical education, Sangeeta also spoke about it. The way the medical students are trained to provide care, is highly problematic. So they look at men and women as a homogeneous group. They do not look at the individual vulnerabilities, and then to add another layer to it, intersectional vulnerabilities of the women. So we need to change that. We need to train our medical students to provide a gender sensitive care, which enable them to address the needs of the women depending on their different identities. And then at the same time, in-service training is also very important, where regular training of the healthcare providers should be done to deliver the gender sensitive care. And then focused efforts on increasing awareness among the community about the early symptoms and the recognition of the especially in the case of the cancer. So there is evidence from literature saying that even if we look at the women from the high economic strata with the high education, that doesn't mean that the women will present to the healthcare provider at early stages of the cancer. So, and the research indicates that what is required is that the government programs need to make concerted efforts to increase awareness among the population about the the signs and symptoms of the early stages of the cancer, so that they can seek care. Yeah, so this was my brief presentation, and I'm open to any questions that the participants will have. Yeah.
Thank you so much, ma'am, for your valuable time. Your insights were incredibly compelling to our understanding of the subject matter, especially the factors that you shared with us that are at play in reality. So thank you so much, ma'am, for your time and wisdom. Now the floor is open for questions from the audience. You can raise your hands or type in the Q&A box. Meanwhile, I request our chair for the program, Professor Vibhuti Patel, ma'am, to add her comments on the session.
Thank you, Dr. Sanjida, for in such a short time you have tried to not only focus on the social determinants of STIs, UTIs, but also link them to the systemic and structural issues, and also talked about the response that medical fraternity and the healthcare system needs to have. Thank you very much.
Thank you, ma'am. Now I request our co-chair, Dr. Manorama Bakshi, to add her comments on the session.
I think chair has already spoken. I think it was a complete presentation. No.
Thank you so much, ma'am. Are there any questions from the audience that we can take up?
You can invite Dr. Anant Bhan. Yeah.
Yes. Seeing none, we will be concluding the session. So thank you so much, ma'am. It was truly an honor to have had the opportunity to learn from you, and we're truly inspired by you. Thank you so much, ma'am, for joining us today, and we look forward to collaborating with you in future for our events.
Thank you.
Thank you, Sanjida.
Thank you, ma'am. Now, I'm delighted to call upon Dr. Anant Bhanji for his keynote address on the topic Assisted Reproductive Technologies. We welcome you, sir. Over to you.
Thank you, Reet, and good evening, everyone. My apologies for having to reschedule my talk to later. I had a flight in the evening, but thank you also for your kind consideration. I know we are at the fag end of the course, and everyone must be a bit tired of all of the information. Though everything has been so interesting, I've tried to follow a couple of the lectures online, and I've seen a lot of interactive discussion also happening. I do also want to thank Professor Patel, Dr. Bakshi, and the IMPRI India team for this opportunity to speak. So I think the topic which was given to me was sort of focused on assisted reproductive technologies, and the idea here would be to maybe just do a quick run through of some of the options on the table, but also talk to you about what this would mean from a women's sexual and reproductive health perspective. So I just wanted to confirm that you're able to see my slides.
Yes.
Yeah,
Yes.
all right, great. Okay. So, of course, many of you know about assisted reproductive technologies. It's already been discussed during the course as well. And in essence, it's the use of technology to achieve pregnancy or conception, especially in individuals who are having difficulty in doing so spontaneously or naturally. Now, many of you will know the history of ARTs as well, and what is well known, of course, is the IVF example, and this was first tried out in 1978 in England. A woman who had actually an unstimulated menstrual cycle, which means that there was no external stimulation using hormones, etc., which was used, and the physicians involved used a laparoscope to retrieve a single oocyte from the ovary, and this was then fertilized in vitro. In vitro means in a lab environment, and subsequently transferred back as a grown embryo into her uterus. And this is when the first test tube baby was born. And of course, ARTs are seen as being a way of helping those who are struggling to get pregnant, achieve pregnancy. And it is an umbrella term by itself, which encompasses a variety of procedures, which include handling eggs, sperms, or embryos to increase the chances of fertilization and implantation. Now, the context is, of course, that one, there is now been growing concern that infertility rates are rising. Already in India, there is an estimate of around almost 10 to 15% of couples facing infertility. I have used couples in inverted commas because many of us in this group would, of course, have issues with just couples, as in heterosexual couples, being the only ones eligible for any kind of reproductive technology access. But in terms of evidence, that's where we are. And assisted reproductive technologies are seen as a path to parenthood for these couples. Many of you would have also seen over the last 10, 15, 20 years a proliferation of clinics which offer assisted reproductive technologies. It's become a huge business within the medical space. It's also been linked to medical tourism, both inward and outward, and just shows that when there is a social demand of some kind, then technology and often sometimes the health profession also fills that gap by making access available. But of course, that has its own challenges as well. And this we, of course, know is linked to social pressures, with children holding significant social importance in terms of family formation, and the sort of distress and which a lot of especially women have with regards to infertility. This is one way where it is seen as responding to that, especially when natural methods have failed. It's also the case that one can argue that with delayed childbearing, as more and more people are taking decisions about having children quite late in their lives because of career reasons, because they want to be stabilized, because they might find a partner later in life, or because they feel that they are ready at a particular point of time. That delayed decisions, of course, can also impact fertility, because as the older you get, the more difficult it is to get pregnant. And for these circumstances, assisted reproductive technologies could be useful, especially in terms of being able to conceive. And also, I think with more awareness around the role of assisted reproductive technologies with infertility, there has been also some impact of that on demand. Now, this is the person that we were speaking about earlier, Louis Brown. Louis Brown was the first person to be born using assisted reproductive technologies. Her mother was Leslie Brown, and two UK-based researchers and gynecologists, Robert Edwards and Patrick Steptoe, worked with her mother and implanted a 2.5-year-old embryo into her uterus. Louise Brown was dubbed as a test tube baby, and throughout her life has been receiving a lot of persistent media attention. A share of the 2010 Nobel Prize also went to one of the individuals involved in the development of the technique, that is Robert Edwards. Now, many of you would also have seen this movie called Ek Doctor Ki Maut, which speaks about the struggles of one Indian doctor called Subhash Mukhopadhyay, who was also trying to develop assisted reproductive technologies, the focus on IVF around that time. At that point of time was largely discredited. His work was demeaned. He slipped into a mental health crisis and unfortunately died by suicide. And that's where the story around the movie also comes from. But later on, it was, as the case records were read through, it was recognized that it was likely the case that he had actually made that breakthrough and pioneered IVF in India, but was just not seen as being capable of having done that. And the discrediting of his work obviously had a huge personal toll on him. For a long time, Harsha was officially recognized as India's first IVF baby, born and this is what ICMR had accepted. Again, important to remember here is also the current success rates are relatively quite high. They're almost 35 to 40%. But a lot of work goes beyond behind that in terms of the kind of interventions which are required, the kind of therapy which is required, and a lot of that can be intrusive and expensive. Now, there are various ways of doing assisted reproductive technologies. The most common one, which is historically been done, is the IVF approach, where there is an embryo transfer. So you basically take eggs, you retrieve eggs from a woman, you then fertilize them with sperms in a laboratory dish, and then you wait for an embryo to develop, and this is then transplanted back to the uterus, and then the normal pregnancy cycle continues. There is sometimes the use of a different approach, which is called an IUI, an intrauterine insemination, in which there is more of sperm selection, especially in cases where there might be sperm motility issues, sperm quality issues. So in a way, more quality sperm are chosen, and then these are directly implanted into the uterus using, again, a technique and an equipment. There is also sometimes a direct injection of a single viable sperm directly into an egg for fertilization. This is typically what is known as ICSI, or intracytoplasmic sperm injection. Then you have frozen embryo transfers. Now, typically in many circumstances when you are trying to gear up for ART usage, many embryos might be created, and usually because only a certain number can be transplanted into the uterus per cycle, some of the leftover embryos might be frozen. So in this case, some of the frozen embryos are thawed and then transferred into the embryo. So these are sort of remnants from previous IVF cycles which are being used. And then you have the gestational surrogacy, and surrogacy, as we know, became quite popular and at the same time has raised a lot of concerns as well, where there is an implantation of a fertilized egg in a gestational woman's uterus for pregnancy and delivery, so she's basically the surrogate for the purposes of carrying forward the pregnancy, because the woman who's commissioning that surrogacy might not be able to, for various reasons, be able to have a viable pregnancy. Now, there are many factors, as we talked about. One is age-related decline in fertility. For women specifically, it might also be linked to blocked fallopian tubes. There might be conditions such as endometriosis, which makes it difficult to get pregnant. PCOS or PCOD also has been linked with low fertility or challenges with fertility. Of course, on the male partner side, you might have low sperm count, you might have motility issues of the sperms, you might have abnormal sperm function, all of which could also make it very difficult for a natural pregnancy to happen. Now, socially and culturally, of course, this is sometimes which is underplayed, and it is usually the woman who has to bear the brunt of social expectations and also sometimes investigations. But at least now, I think there are more open conversations about potentially there being medical issues with the male partner as well. And of course, important to remember that as we have more and more NCDs and chronic morbidity increasing in India, that chronic diseases can also have an impact on fertility. Interestingly, there's some evidence around the role of psychological distress and fertility as well. And it indicates that psychological stress by itself could be a clinical risk factor, which could be reducing male fertility. In fact, in studies have shown that in comparison to their healthy peers, people with diagnosed infertility problems might also face a much higher frequency of psychological problems. And this could also be linked with the stress associated with being labeled as being infertile. And this has been demonstrated to be showing through via mood disorders, anxiety disorders, etc. Eating disorders like obesity, bulimia nervosa, and anorexia nervosa have also been linked sometimes to infertility. Now, if you look at how this pans out from a technology availability perspective, especially in India versus, let's say, high-income countries, I think right now we are at a stage where almost everything is available in India. It might just be that certainly some more cutting-edge technologies, which also have their own unique ethical issues like pre-implantation, genetic diagnosis, etc., that might be much more widely used or available in high-income countries. Average success rates are already getting quite high in India, but they might be higher in high-income countries because of better technologies, experience, patient selection criteria. The cost is significantly lower in India as compared to many other high-income countries, but that is also still a high cost for a large segment of our population. Because we are already talking in the private sector of somewhere in the range of 1 to 5 lakhs per cycle. In the global north, a lot of this cost is even higher, but some of that could be covered by insurance. In terms of regulation, we have ICMR guidelines for our ART practices, and there has also been recent legislative updates, which many of you would have heard about, the ART bill and rules, the Surrogacy Act and rules. Similarly, in high-income countries, there are often strict regulations and ethical oversight may exist. Public funding, there is very low public funding. There is no national public funding program for ARTs in India. So there are public sector institutions which offer assisted reproductive technologies in many parts of India, Delhi, Mumbai for sure, other parts also where these are being available in now government hospitals. But there is usually some cost attached to it, though it might not be as high as it is in the private or corporate sector. And in the global north, again, there might be some contexts which offer some level of public funding for ARTs. Now, if we are categorizing access to reproductive rights as a form of human rights, which is what a lot of bodies such as the UNFPA have also argued for, then we would recognize that that would also extend to having access to technologies which allow people to decide the number of children that they have, the spacing and timing of the children, how they have children, and also this being free of discrimination, coercion, and violence, as is already expressed in most human rights documents. If you look at the ICESCR, specifically the International Covenant on Economic, Social, and Cultural Rights, it also specifically talks about the right of all persons to benefit from scientific progress and its application. And the development of these technologies is a form of scientific progress and its application, because of course these technologies were not available a few decades earlier from now. So these advances can be used for fulfilling reproductive rights, but of course they have their own caveats as well. I think there's been some really good sociological analysis of why is it that, for example, people are much more comfortable with the use of assisted reproductive technologies as compared to even adoption, right? Because adoption rates have increased in India, but there still seems to be a relative more stigma attached to adoption as compared to even the use of assisted reproductive technologies. And I think this analysis by Aditya Bhardwaj, published almost more than 2 decades ago, speaks about the stigma associated with infertility treatment. And this is partly, from his perspective, coming from a place where the inclusion of a third party in this whole exercise is somehow seen as being disruptive, because there is a culturally priced ideal that there is an intimate connection between the married body and progeny, and adoption clearly indicates that there is this child who's been brought into the family, but that child doesn't have a direct biological link with the parents, and this could be something which could stigmatize the parents, because it would be a public, vocal, and visible admission of infertility, which cannot be hidden in the same way that you could hide the use of assisted reproductive technologies, right? Because there you could be going to a clinic, you could go out of station, you could wait for the woman to get pregnant, or you could be using a surrogate, but by keeping that whole exercise hidden, you could still claim that it is your biological child, right? So for some reasons, that might be partly explaining why IVF use or ART use is much more widely accepted as compared to adoption, which one would think should be a viable option for many individuals who want to have a child. There are, of course, other ethical issues as well in the use of assisted reproductive technologies. As I mentioned, ART procedures can be very expensive. They include the cost of medications, consultations, lab fees, and typically for many of you might also have had experiences with this among your own circles. Sometimes a single cycle is not enough. You might actually have to do multiple cycles of therapy. And all of that, of course, then adds on. And this could be a financial barrier by itself for those trying to access assisted reproductive technologies. Remember that this is just the cost of these cycles and treatment, but there is a lot of out-of-pocket expenditure. There are lost wages, work days, as people have to wait for their turn, have to get hormonal injections, have to donate their oocyte or sperm, etc., come to the clinic for that, sometimes spend long hours, and then follow up for the testing to see if that has led to a viable pregnancy, etc. And also larger questions around the use of donor sperms or eggs. Should sperm and egg donors be anonymous? Is it ethical to compensate these donors? If so, how much is appropriate? What are the rights of the child? Can the child also have a right to want to know who their biological parent or parents might be in case there is a third party involved? Issues around exploitation of women, especially in the use of surrogacy. And this, I think, has had a lot of discussion happen in India, including in the women's rights groups, the women's health advocacy campaigns around. Can we be thinking that commercial surrogacy is exploitative of women, especially of those who are coming from economically disadvantaged backgrounds? The corollary to that is, if there is labor involved, in this case reproductive labor, is it not fair that these women are compensated in some way? Should we really be moving towards a model which is purely altruistic in nature, and not recognizing the kind of bodily labor that is involved in becoming a surrogate, right? There are questions also around parental rights, who are legal parents of children born to surrogacy, the psychological impact on the surrogate mother who has to give up the child once born, also the intended parents and the child, and is this something which has invited careful consideration? Now, usually in IVF, because they are trying to enhance success rates, there is often the case that multiple embryos might be created. Now, in some cases, there is an approach called a selective reduction, where you reduce the number of embryos implanted to increase the chances of a successful pregnancy, right? But then some embryos are discarded in this. Some embryos might also be donated and frozen. But what are the considerations, especially from an ethics perspective with this? It's also important to remember, especially for a course focused on women's health, that this whole exercise and discussion again reinforces this whole idea that women's health is often reduced to maternity and childbearing. And even the use of technology in this sphere is largely focusing on how to make that happen, right? And also the side effects which are there, because for women who are undergoing workup for infertility treatment, there is a lot of hormonal therapy which is used, other medications which are used, which have their own side effects as well, right? And also the pressures involved. For example, if you do get pregnant of the use of ARTs, and that has happened after a long struggle, then the pregnancy by itself is seen as being a precious pregnancy. You might be asked to take rest at home. You might have to take leave from your job, leave your job. There might be a lot of pressure and stress with having to retain that pregnancy, not do anything which could potentially lead to any kind of poor outcome, and that by itself also can certainly be quite stressful. From a societal perspective, of course, there is a positive spin which is given to the use of ARTs, and that's what you would hear in popular discourse, that it helps in the fulfillment of parenthood, something which is a deeply cherished desire in Indian culture, will bring joy, strengthen families. It can help women take decisions about delayed child bearing, because technology can help them. This can help them, settle down in their careers, and then when they are ready to be able to then make choices. Hence, you also see all of this discussion in popular media around women deciding to freeze their eggs so that they are able to then at a later date, retrieve them and take decisions about childbearing when they are ready. There is also now more open discussion. I mean, there are large conglomerations, hospital chains which offer IVF, which offer ARTs, and there are more open discussions around it. This is, of course, also linked to larger cultural issues or considerations which are linked to patriarchy, as we were already discussing earlier, that having biological children is seen as being critical to carry on the family lineage, and ARTs are seen as one pathway to do that. Family decisions, religious decisions can also influence decisions about ART usage. Of course, son preference is still a factor to deal with, as we've had a lot of technology introduced, regulated, etc., including around the MTP Act, the PCP and DT Act. It's still the case that assisted reproductive technologies could be misused. And of course, there are mechanisms to try to protect against it, but we know that occasionally they are not successful, and this remains an issue. Now, in terms of technology and future usage, there is a lot of work which is already happening, as is true with any other field across the board, but also specifically in health. You have AI and ML potentially, which can help personalize treatment plans, predict which embryos might be more viable, and improve selection and matching of patients to specific ART procedures. You have in vitro maturation, where the maturation of eggs is happening outside the ovary, so that women, especially with diminished ovarian reserves, are able to access that. There is talk of artificial ovaries and wombs, where everything would happen outside the body, and these artificial organs would be used for both egg development as well as embryonic development and then fetal development, etc. There are better technologies being developed for sperm analysis and selection, so that more and more better quality sperm can be selected for assisted reproductive technologies. There is work happening in the pre-implantation genetic testing space to try to screen embryos for genetic diseases, but this by itself also, of course, is fraught with a lot of ethical issues. The disability movement also has concerns about this, because then this is almost framing any child who is born with a disability, because let's say they have a genetic disorder, as being problematic, right, or a poor outcome, and that questions the quality of life which someone with a genetic disorder could have. The use of telehealth, remote monitoring, there is a lot of focus now also on fertility preservation, as I was already saying, with people deciding to freeze their sperms or eggs. And this is becoming more affordable and efficient. So long-term sort of storage is also being used. Now, in terms of the regulatory response to the development of assisted reproductive technologies, especially in India, SAMA, which is a well-known women's health NGO based out of Delhi, did this very interesting charting of how the regulatory developments happened in India, right from commercial surrogacy becoming legally available in around 2002 in India, to the development of national guidelines for accreditation, supervision, and regulation, to draft ART bill, which was introduced first by MOHFW in 2008, to then the recognition that we should restrict the age for someone to be a surrogate between 21 and 35, to excluding single persons, gay couples, and unmarried couples to being able to access and commission surrogacy in India. And then government banning commercial surrogacy, foreigners being prohibited from accessing or commissioning surrogacy in India, to later on the whole development of the bills and subsequent passing of this in both the Lok Sabha and Rajya Sabha, and the formulation of the rules. So there is this almost more than 2 decade sort of path of how the regulatory system in India has played a little bit of a ping pong, like a table tennis match, with being sometimes very permissible to sometimes becoming more stringent, and now we have this. So now, if you go and see how these acts and rules are really being implemented, one mechanism is through the development of a registry which tracks where is it that these clinics are, and also where is it that these banks are, which are offering these kinds of assisted reproductive technologies. Then you also have a portal which is also providing information. The portal has information on state ART and surrogacy boards, appropriate authorities, the national board, etc. They also have a mechanism for registration of ART clinics. So there are 2 levels of ART clinics as per the legislation. One is a level 1 ART clinic, where typically only one ART procedure is being carried out. Usually this is intrauterine insemination. Level 2 ART clinics have a whole range of services which are available. This could include retrieval of gametes, handling of oocytes, and use of sperms, transfer of embryos, storage of gametes or embryos. And these clinics, which are level 2 clinics, are also permitted to carry out research-related activities. ART banks are the other sort of institutions which are mentioned in the regulations, and here these banks are supposed to be responsible for screening, collection, and registration of semen donors, for cryopreservation of sperms, for oocyte donors to be able to donate oocytes, and basically banking these gametes, either the oocytes or sperms, and also maintaining a database of all of the donors and updating the national registry. So some research has tried to find out how have these regulations impacted the practice of assisted reproductive technologies. And this paper specifically published a year earlier from now, in May of 2023, asked this question of the providers, so doctors who provided assisted reproductive technologies. And very interestingly, as you will already see, many of these clinics which responded are offering a whole range of assisted reproductive technologies, IUI, IVF, ICSI, with the use of donor sperms, etc. And also largely have had a positive response to the development of the regulations and acts. So almost more than 80% saying, yes, there was a need for regulation to happen. But they all seem to have a major problem with the gamete donation provisions, because the way they are pitching it is that this is increasing the cost of IVF and ART treatment in India, because you have a limit around the usage of these gametes which are provided, right? So their point being that in urban areas, endometriosis is an issue. In rural areas, TB is a major issue. And donor cycles are becoming more and more difficult to do and expensive to do. And the reason for this is that the ART Act requires that gamete donation not be compensated, and that a donor's gametes, whether those be sperm or oocytes, are only used by one couple. And there are limitations on the number of eggs and number of times an egg donor can donate eggs. And their perception is that this will make it very difficult for donor gametes to be used. It will also make it expensive in terms of the technology usage. And this will increase the cost of the donor cycle. And they've also questioned whether it's really practical to expect donors to not receive any compensation, right? And this is where I'm saying this is again the provider perspective on this, and also the costs. Now, what's interesting is also, I think governments have woken up to the idea that there seems to be a patient preference, community preference for assisted reproductive technologies to be available. And hence, we are seeing more and more public hospitals starting to offer these therapies, which was earlier not the case. It was largely mostly available in the private sector, but now many government institutions are offering it. As I said, there are still some costs attached to it, but it will still be much more cheaper than going to the private sector. There is attempts being made at self-regulation as well. So the Indian Society of Assisted Reproduction is an example. They came out with guidelines using an ethics committee where they talk about what is the maximum number of embryos which should be transferred in any cycle so that you don't overdo it. You limit the number of embryos. You also have to look at what kind of services should we be offering women who might be at high risk of complications during fertility treatment. These are many women who have chronic conditions, who might have cancer, etc. What do you do in couples where there might be one of the partners might be HIV positive, so serodiscordant couples? And now, of course, as we know, with the availability of medication, you can bring down your viral loads quite low, but still, how do you approach fertility treatment in these circumstances? And then should there be an upper age limit for the use of assisted reproductive technologies? As we have seen in the past, there have been news reports of people in their 60s, 70s, probably even the 80s, using assisted reproductive technologies to get pregnant. And is that acceptable? Should there be some kind of upper age limit which is defined and not allowed to be crossed? Again, we've seen circumstances where people, if they've not been able to access it because of these kinds of restrictions, have gone to other parts of the world to access assisted reproductive technologies, Southeast Asia being also a favored destination. Now, of course, groups like SAMA, as I mentioned earlier, have spent a lot of time tracking the development of ARTs, from a women's health perspective, from an advocacy perspective, from an ethics perspective, and have questioned the sort of change of the law and regulations, which now mean that altruistic surrogacy is only available for heterosexual Indian couples who've been married for more than 5 years, which is disqualifying a whole lot of other people on the basis of marital status, age, sexual orientation, and nationality, because this is only available for Indian couples, as we said. And then you have issues around heteronormative, morality-laden frameworks that prioritize a certain experience of childbearing. And while the legislation right now around surrogacy seems to be focused on trying to prevent exploitation, it also disregards, as I was earlier saying, the value of women's reproductive labor in the context of surrogacy, given the substantial efforts involved and the lack of a contract, the reliance of an altruistic agreement, which by itself is problematic. Very quickly, I think there has also been critiques and very valid critiques about the fact that, as we were discussing earlier, that this is a very heterosexual construct in the way right now ARTs are available in India, and leaves out a whole section of the population, whether those be single, whether those be individuals who are queer, with a partner or without a partner. And colleagues such as Salik and Shivkami have made the argument that maybe we should be perceiving families not around gender and sexuality, but around the kind of love and care which this kind of a formation can bring. And while courts have talked about potentially queer relationships and unmarried relationships, live-in relationships, for example, falling under the idea of a family and being protected under law, these kind of non-traditional forms of families don't have access to the use of technologies such as ARTs or even surrogacy, which can provide avenues to parenthood, because they're only available to heterosexual married couples who have been married for 5 years, as we were talking about. And this excludes a large segment of the population who, for valid reasons, might want to access ARTs for purposes of parenthood, and is that something that we need to problematize? And in terms of expectations, of course, research also this time, in this case, this is coming from Canada, but talking about what would be an ideal situation where assisted human reproduction services were available for queer identifying individuals and couples, and expectations around information being provided, patient-centric practices being implemented, training to be LGBTQIA plus affirmative, increasing visibility of people who are also queer in the clinics as providers, and also service gaps, which can be something which can again trigger negative responses among queer folks who are accessing treatment. So trying to respond to all of that would be a situation which would help provide better affirmative care. So these are just some references. Again, the idea here was to speak about the role of technologies, the kind of range of technologies which are available, some of the ethical issues involved, the critiques which are there, some of the recent legislative developments, and again, some of the challenges and questions around the way these legal developments have been constructed, and the kind of implicit patriarchy and focus on heteronormative interpretations of relationships which is there, and how that needs to be also something that we should also be looking at and hopefully arguing for the need for change for. So I'll stop there, just acknowledging some colleagues who helped with the presentation, and thank you for your attention.
Thank you so much, sir. That was a very comprehensive presentation, and it shed light on a very important topic. So thank you so much, sir, for your time and wisdom. It was truly great to hear your presentation. Thank you so much, sir. The floor is now open for questions from the audience. You can type in the Q&A box or raise your hands. Meanwhile, I request the chair of our program, Professor Vibhuti Patel ji, to go ahead with her comments on the session.
I think my only comment is that that's such a complex issue. Dr. Anant Bhan has explained in such a lucid and erudite way. And he has also dwelled on a global experiences and the socio-cultural setting in different contexts, geographical contexts, and lifestyle factors. And the most important aspect of his presentation is that the whole processes involved in ART, about which there are so many misconceptions. People are ill-informed. I think all those processes have been explained in a very lucid and palatable way. I think there is a question about in the chat box also for him.
Yes, ma'am. Just before that, Manorama, ma'am, would you be able to give your comments on the session? I believe you were driving.
I think this was a wonderful presentation. I don't want to give any comments, Reet. Take the questions from the audience. Thank you.
Thank you so much, ma'am. So first of all, there's a question by Uma Chaudhary ji. You can go ahead.
I just want to know, sir, can we have some proper guidelines about these things known to the general public as well? Is there any procedure in which general public can be made aware of these guidelines about MPP and other things? Because I think if that can be done at any end, it will be really useful, at least for Indians. Thank you.
Absolutely, Umaji. I think that's an important requirement. In fact, true of any technology or health intervention, whenever we're talking about clinical practice, we speak about the need for true, valid, informed consent, and part of that is, is laying out the options, right? And typically, any good performing ART clinic will actually have counselors who are available, and the role of the counselor there especially is to lay out the options, is to talk about all the options, including the fact that your option which works best for you might also be an option where you should not be accessing assisted reproductive technologies, because it might not be the right fit for you at that point of stage of your life, and then encouraging the person or persons concerned to think about potential delay of decision, potentially not having a child, or potentially adopting. But if they would like to go ahead with ARTs, then telling them what is right now available on the table based on their health status, the tests, etc. What is feasible? What are the success rates like? What are the costs involved? What are some potential side effects? So that the person at the other end, or the persons at the other end, then have that information available to make a decision. The larger issue around public engagement, of course, is extremely important. And that's where I think all of us have an important role to play. And maybe the purpose of courses like this and the design of such courses by Professor Patel and Dr. Bakshi and other colleagues at IMPRI is to encourage us to think about some of these issues so that the conversations that we have in our own circles, many of you are teaching at universities, many of you are involved in working with communities and NGOs. Maybe you can take some of these conversations back and talk about the importance of choice, talk about how patriarchy also is driving a lot of commercialization of technologies. And while we should celebrate technology and advances, we should also remember that this is sometimes just playing a supportive role in reinforcing some cultural and social stereotypes, and we have to guard against that so that it doesn't become another way of putting pressure on women around ideals of femininity and motherhood. So that's something, again, I think all of us can perhaps take back and reflect on how we can take those conversations back.
Thank you, sir. Thank you so much.
Thank you so much, sir. Priyanka ji, you can go ahead with your question.
Yeah, thank you, Reed. So my question is regarding the genetic testing in IVF, genetic testing of the embryos. If that is something that can be done, as you said that one of the cons of it could be the gender selection coming into play here, then does this come or not under the selection, the sex selection law that India has going on? And another one was that regarding the embryo donation, is embryo donation something that is done by the consent of the couple who's had the extra embryos, or like, is the ethical nuance there that the couple is not aware of it? These are my questions.
Yeah, sure. Thanks, Priyanka. So yes, the earlier version of the Act, the PNDT Act, did not really foresee the role of pre-implantation techniques, which is why later on the revised Act, which talks about preconception and prenatal diagnostic techniques Act, actually then also covers this issue of the use of pre-implantation techniques to sex select, right? Because you could choose to be able to pick on an embryo which is a male embryo and then only implant that. So that, of course, is covered. But as I said, there are loopholes and people might be taking advantage of it. Also, some of these are available in other parts of the world. If you are financially well off, that family could potentially go to another part of Asia and access some of this. So it doesn't really, and we know also of celebrity cases recently where older couples who have lost their sons have accessed this, right? So I don't think we need to talk about who specifically. That's immaterial, but that's an example. The issue around well, one is potentially sex selection being an issue, but there is also the critique, which is a critique about ableism, which treats any form of a disorder, let's say a genetic disorder or a disability, as some kind of an aberration, right? And this especially comes from the disability community, which says that by actually allowing for these kinds of selective techniques to be used, that you are lessening the value of a life of a disabled person or a person with disability, right? And that, I think, is also a valid critique to think about. Now, of course, there will be some forms of genetic abnormalities where viability is not there, right? That fetus might not be viable, or if born, then the likelihood of survival is very, very low. That isn't case where potentially there might be a situation where there might be more consensus about the need for intervention. But someone who might be having Downs, who might be having other conditions where people have lived very fulfilling lives, if they are born, then I think that's the larger question of, are we the ones to decide what is a quality life, right? And a person's with lived experience, what is their sort of weighing in on that? So I think that's a larger discussion to have Because as more and more technologies become available, some of these ethical challenges will happen. So that's what I was trying to hint towards also, that we should be looking at critiques coming in from disability communities around some of these technologies and their developments as well.
So regarding the chromosomal aberrations, is it possible for the clinics to inform the patients or the probable parents of the genetic aberrations, for chromosomal aberrations, without telling them about the sex of the embryo?
Yes, and in some cases, yes, absolutely. And I think that's what is allowed for. And that's why, again, as I said, you need to be careful about what you are divulging, because some of these are also linked to sex chromosomes. But in some cases, of course, you can and talk about the options on the table, including the option of not going ahead with the pregnancy. And in some cases,
And so is the
and in some cases, if there are genetic issues.
no, so I just wanted to.
Yeah, go ahead, finish your
So
question.
I just wanted to understand that the process of being a donor, whether a sperm donor or an egg donor, it is anonymous. Like if a couple opts for sperm, for sperm selection or egg selection, they will not know of who's the donor is. Then in that case, whosoever is the donor in the clinics, are they priorly tested for like the genetic testings and the blood tests and everything? Is all of that followed through?
Yeah, that's part of the workup which will typically happen, just as we do it for blood or any other tissue which is being donated. But of course, as we were discussing during the presentation, that the expectation that all of this will be altruistic and that you will only have, one donor linked to one family, etc. This is making it a little bit challenging. But on the other end, we have also seen a lot of misuse, right? Where you have some kind of people who have sometimes used, there have been doctors in the West who use their own gametes and use that to make a lot of pregnancies possible in their own clinics, and that becomes a controversy later, because then you link it back to one individual and there's like 300 kids who are born using that, right? So we need to also make sure that there is some regulation there. But I think these are also issues and challenges which are coming up as the act is being implemented, and we will probably hear more about what are the kind of on the field, on the ground issues which emerge.
Thank you, sir.
Thank you so much, sir. Shefali ji, you can go ahead with your question.
Thank you. Hi, good evening. Let me introduce myself first. I'm a PhD scholar working on infertility and IVF in the context of Jharkhand, where I'm trying to understand from an ethnographic research the ways ART clinics have started mushrooming in the past 10 years, especially when Jharkhand is a newly formed and developing state and falls under the EAG category, where the MMR is very high in the state of Jharkhand. I don't have a question per se, but I have a few observations which I would like to share so that we can have a broader stage and platform to discuss some issues within ERT. First is how infertility, the term itself is missing from the public health discourse. And one of the ways to see about it is that it is in a very small form. There's a discussion about infertility in NFHS 4 and 5. The space of infertility has been given within the NFHS is a very small. And secondly, the fact that ART clinics are mushrooming, does it talk about the growing rate of infertility in India? And if that is so, why is it still not being discussed in a public health platforms or sectors, not by the government? The only policies which has come up around ART is in the ways of doing ART and not around infertility. That is a kind of, I think through this platform, we as a group of people who are sensitive towards gender, we should take up courses around discussing infertility within the public health discourse rather than alone doing the ART and the ways it is done. That is A. B, like Priyanka was just talking about how around the gamete donors, I would like to bring it to the platform that when the center was asking for the recommendation from each state around ART before the bill was signatured into an act, Jharkhand state had given the recommendation around provisioning of gamete donors, and which was taken by now what the act is. It says that any woman who is married and is below the age of 35 and has at least one child from her marriage can donate an egg on an altruistic form. Unfortunately, from my fieldwork and data, the scenario is very different. It is not altruistic, A, and there is no checkpoint checklist to understand if the woman who is about to donate the egg is fitting into the criterias made by the policy. So those are the ethical issues within ART. And I'm still, like I said, it's an ethnographic work. I've not reached where I can comment per se as to what to be done. But I would like the stage to, speakers here to throw some light how, as a gender studies researcher who's about to finish my PhD, and how can we discuss it and problematize all these issues in future. Thank you.
So I think, Shefali, you're absolutely doing what you should be doing, which is one, of course, sort of bringing the reality from the ground by your ethnographic explorations, and I think these are extremely important findings to bring to the fore as well. And of course, these are fora like the one where you have the course, but also your writings, both academically as well as hopefully for mass media, etc., will help bring light to some of these, real aspects of how things operate on the ground. And I'm totally with you when you say that it's important for us to recognize infertility also as a public health issue. And to some extent, some governments are trying to respond to are starting to respond. There are more departments, etc., being created in public institutions. But still, I think it is largely the realm of the private sector. And this mushrooming is also because, again, there are two aspects to this. One is technology being available, technology being a commercial win, because there is a lot of money to be made out of the business of creating a baby, and that is also because of the social sanctioning around the importance of having a child, which means that people are willing to spend that kind of money in the chase of becoming parents. So I think everything sort of adds on to why there is this mushrooming happening. There are chains which have invested a lot of money, and they encourage people to get tested. There are pressures, even with perhaps before waiting adequately to try out naturally, people are already being encouraged or to get tested to access assisted reproductive technologies. There are a lot of things at play, some of which is also unethical practice, which is relevant, which is why, of course, we also had the need for legislative interventions. But the legislative interventions also, of course, take a certain angle to philosophically, which is again reinforcing some of these stereotypes which we have already discussed. So again, I think your learnings from the ground and sort of speaking to those would be extremely important for us to understand also from Jharkhand and hopefully other contexts. How is this operating on the ground? How does it impact communities? What are the perceptions? Who are actually involved? And again, are they in line with what the law says, or there is another thing happening which the law has clearly failed to address? So thanks for again working on this, and look forward to reading your findings when they're published.
Thank you so much, sir.
Thank you so much, sir. There are two more questions. If you allow, could we quickly take them up as well?
Sure. Go ahead.
Nikita ji, please go ahead with your question. Meanwhile, could Dr. Tane Trivedi ji go ahead with his question? Okay, I'll just read out both of the questions from the chat box. The question by Nikita Sharma ji is, selecting desired sex is reproductive liberty and in many countries is legal. What's your opinion in this matter?
Yeah, I think that's a larger discussion, but certainly, I mean, in many countries where perhaps sex selections and preference is not so much of an issue, this is seen as a way of, in inverted commas, balancing of a family. You might already have, let's say, one or two male children, and you want to have a female child, so you want to use technology for that purpose, or vice versa, etc. Yeah, but the social reality in our context is certainly very different. In fact, very interestingly, there is data which indicates that South Asian immigrants to countries such as the UK and Canada also carry some of these preferences with them, and there is data which indicates again that technology is used there for some preference purposes as well. So even if some of these contexts have more liberal interpretations of being able to use technology for choosing the sex of the child, we have to again contextualize that with why is that decision being taken? Is that for really having a balanced family, or is that reinforcing male preference in that culture, and how do you deal with that, right? Because then if that is basically just taking something which is problematic from India to another country and using more permissive approaches, then that by itself is still a problem. In a world where this was not a challenge, would people have the right to choice? Maybe yes, but if it was also potentially going to be misused, then maybe there was a need to also do it in a way that there is some level of control to ensure that it is not being used for reinforcing something which is a social ill, or something which is problematic.
Yes, sir. Thank you so much, sir. The next question is by Dr. Tanhit Trivedi. The question is, I would like to get to know if from your end about the status of civil union for the young couples in India that don't wish to get married but wish to co-live and bring forth the newer generation to life as parents. Is ART a better option for them or adoption? So such couples technically not married are we having legal acceptance above the status of live-in relationship and below the status of marriage for them to avoid any kind of post-matrimonial property disparities and dispute that come with female favor-oriented laws of date, just in case if they wish to part ways and move on with their respective lives post few years of civil union? Thank you.
Yeah, so Tanay, that's a little bit of a complex question. I think there are multiple parts to it. One is, of course, this issue around is it better to adopt, or is it better to use ARTs, or is it better to have children naturally if they are capable of? Again, I think that decision has to be of the couple, and they have to make that decision. If they are ready for parenthood, then they have to take an informed decision about that. There is now certainly more and more legislation which is recognizing live-in relationships and the rights for both partners. You could argue that is that more more in favor of the woman. I would dispute that in the sense that, again, it's part of a larger paradigm where there is also the concern around potential exploitation. Of course, one could always see what are the mechanisms to ensure that it's more equitable. But I think specifically because the topic is around ARTs, unfortunately, right now, ARTs are not available to couples who are not married, who are not in long-term heterosexual relationship, which is legal in nature in the sense of being married. As I mentioned, it's for 5 years. And so it excludes live-in relationships in the way it is being described right now. Will it change over time? We don't know. Maybe it will. And hopefully it will, so that it is more egalitarian and available to those who need it, based on, and doesn't put a value to marriage per se as a qualifying criteria. The larger issues of civil unions, live-in relationships, property matters, etc. I think a lot of that is probably going to be tested in law, and we might have judicial again, precedents which defines us what is acceptable, what is not acceptable. But I'm sure in the coming years, this will be an issue which does keep coming up repeatedly. But thanks for asking that question.
Thank you so much, sir, for answering the question. With that,
I would just like to add one sentence that none of the matrimonial property laws are favoring women, because reality shows that women are even UN data says that women own only 1% of world's property. Okay, so that means whether you go by the religious law, customary law, family laws, and the matrimonial property law, women are not getting. In fact, the unpaid care work which women do in such union, whether in a live-in relationship or in a married life, it's not even considered as a work. It is not a market. Cooking, cleaning, caring, and looking after the sick. That's a major debate.
Yes, ma'am, definitely. Thank you so much, ma'am. Now, I believe that was the end of all our questions. And with that, we will be closing this session. So first of all, I would like to thank sir for articulating such complex concepts and patiently addressing all our questions. Thank you so much, sir. It was truly a privilege to have learned so much from you today. We really look forward to welcoming you back in our future events. Thank you for your time.
Thank you. Thank you, everyone.
Thank you, sir. Now, lastly, we would be going ahead with the quick feedback session. Since this is our last day of the course, I would request all the participants to either unmute or type in the Q&A box anything that they appreciated about the course, any changes that they would have liked to see, anything we can improve on for our future courses. Please do give us your opinion, as it will help us to make the course better. Is there anyone who would like to speak?
Yeah, ma'am, I would like to speak.
Yes, please go ahead, Umaji.
Yeah, this entire course was really very meaningful, at least for me, because I'm not from typically medical background. I'm from a research background, and what I was expecting, I got out of this course. So I'm really thankful to the organizers. I'm really thankful to ma'am, both of you, Professor Vibhuti, ma'am, really thankful. And what I suggest is maybe it can be taken for forthcoming courses or whatever programs IMPRI is going to launch, that some of the sessions can be, the course can be in a hybrid mode. So we can have some offline interaction also, especially for those participants who are Delhi based it will be really good. That is just a suggestion if it can be taken. Thank you.
Yes, Umaji, definitely. Thank you so much. Is there anyone else who would like to go ahead? I've also shared the Google form for the feedback session on the chat box. This will also be shared with the video of today's session. You can fill it right now or later when you receive it through your email as well. Is there anyone else who would like to go ahead with their comments?
May I speak?
Yes, Aditi, please go ahead.
This was a wonderful course. Each and every speaker so thorough, so knowledgeable. I think I just got pearls of wisdom all throughout these 4 days. And each and every session was comprehensive, covering all possible points. In fact, even the future possibilities, like today's session where Sir spoke about the possibilities of, future ART and stuff coming up, cutting edge technology and all of that. So I really enjoyed the session, all the sessions, in fact. And I thank you so much for organizing such a wonderful course. In future, I'll definitely attend anything that's, related to my field, coming from IMPRI. Thanks a lot for this opportunity. Thanks.
Thank you so much, Swatiji. Is there anyone else who would like to go ahead? Yes, Lakshmi Chetriji, please go ahead.
Hello?
Yes.
Can you hear me? Okay. So, yeah, this 4 days
session was very, very insightful for me. I have limited experience working on this area, but this area is very, very close to me, and I really want to learn more and understand it better. So when I came across the brochure, and then I was very excited and wanted to, enroll in this program. And today I'm happy, and I got most of the sessions were quite insightful, and especially today's session and the topics which were dealt were quite comprehensive, as my other friends have also mentioned. And some of the topics were not so much explored, like the last session. So was very new to me, and now I feel like I have to read more, and so I am starting to feel that, and I feel the need of learning more about this, and I'll be really willing to join in the future course also, if such programs are organized by IMPRI. And thank you to all the experienced and all the facilitators and all the speakers for the wonderful presentation. It was very much insightful for me. Thank you.
Thank you so much, Lakshmi ji. Is there anyone else who would like to go ahead? Okay. Seeing
One,
Yes.
I just wanted to find out from Vibhuti ma'am and IMPRI also. Greet ma'am, you can also just if there is any possibility of launching such courses in collaboration with our colleges of Delhi University, can also be explored.
We have had collaboration with NFOIA deemed to be University Center for Ethics, and previous two courses on engendering medical education and gender and health care system. They were done in collaboration with the NFOIA, and I think the third course is also coming up in the month of August. Yes, with the
And ma'am, I saw one of your this thing. There is some, I think, internship, 4 months internship for students, and so I was just wondering if I'll just check with my students if they are interested, some of them, and probably if my daughter is also coming in from US, I think I will ask her to enroll. So and we can also think of some future such programs in collaboration with our college. And Madam, Dean of Colleges of University of Delhi is very good friend of mine, so we can think of having a collaborative programs. Thank
Even
you.
faculty development program also can be done on this issue.
Yeah.
These are untouched
Yeah,
by the
FDPs
refresher
would be
courses,
really good
orientation
because-
programs.
Yeah, FDPs are really required, and this will really help. So if need be, I will be happy to collaborate. That is what I will. Thank you.
Yeah.
Definitely, Umaji, that's something we will definitely look into. Is there anyone else who would like to add anything?
Hello?
Yes, ma'am.
What?
No, ma'am, I was just asking if there's anyone else who would like to add their comment.
Okay. Shubhra ji, you wanted to say something? Please go ahead. Nikita Sharma ji.
I'm audible?
Yes.
In these 4 days, I learned many things, and thanks to Dr. Patel and Manorama ma'am and all speakers. Thanks to Reet ma'am also. You conducted it very well. Thank you so much. Thank you.
Hello, Shubhra here. So many things are very new to me because I'm just in the field, and such experiences were not happens. हम अगर हिंदी में भी कुछ कर पाए तो ज्यादा अच्छा लगेगा, क्योंकि आई कैन पार्टिसिपेट एंड आई ट्राई टू take my colleagues here, but it was difficult for them to. So, but it will be more, I mean, it should be there. So the field workers could.
नहीं, कई किए हमने, जो दहेज के खिलाफ था वो हिंदी में किया था हमने।
अच्छा।
तो फिर और इनफॉर्मल सेक्टर वर्कर्स का वो भी किया था। वहाँ पैनलिस्ट भी हिंदी में बोल रहे थे और पार्टिसिपेंट्स भी। लेकिन फिर प्रॉब्लम हो जाता है कि ईस्टर्न इंडिया के लोग नॉर्थ ईस्ट के 7 सिस्टर्स रह जाते हैं, बंगाल को प्रॉब्लम होता है और साउथ के 5 राज्यों को हो जाता है। So that is that big concern. But I think we should think of
Thank you so much. Dr. Varshaji, you can go ahead.
Yeah. Hello, everyone. Am I audible?
Yes, madam.
Yeah. So as I mentioned on the first day itself, I am an Ayurveda practitioner with a specialization in obstetrics and gynecology. Right now, I am pursuing my PhD also in the same. So since all the topics which were covered here were pertaining to the modern medical science, so I would like to extend my hand towards IMPRI if they can collaborate with some Ayurveda practitioners and bring about some sessions which will focus on our indigenous science of Ayurveda, which can be offered to the persons who are yet to explore the knowledge and benefits of Ayurveda. Like, I would like to add upon here, like the last session we had was of ART and IVF techniques. So I had many patients of mine who had conceived after many failed IVFs. So with pure Ayurvedic treatment. So I would like to extend my helping hand towards IMPRI if they can collaborate and what you can say, we can have some event where the insights of Ayurveda are explored with respect to women's sexual and reproductive health.
Yeah. Yes. Because you are in Anant, which is epicenter of ART, and still people are coming to you. That means that must be very important contribution which Ayurveda has to make, and we accept, yes, that such efforts are very good.
Yeah, thank you so much, ma'am.
Thank you.
Thank you so much. Is there anyone else who would like to go ahead?
I just want to ask one thing. Can I share with other friends the links you are sending?
Yeah, it is so.
Yeah.
It's meant for public consumption. Most of the knowledge products of IMPRI are extensively used not only in India, all over the world, because otherwise everything is password protected while IMPRI's resources are in public domain. Yeah.
Thank you.
You can freely use them.
Is there anyone else who would like to go ahead?
That is why the choice of resource persons also, they are not only expert in their own field, but they also believe in democratization of knowledge. They don't want to sit on the knowledge like a cobra. No? So they are the people who believe in sharing and reaching out. So these are the kind of resource persons we always choose.
Yes, ma'am. Are there any other comments from the audience?
May I?
Yes.
Oh, okay. Thank you so much for this 4-day immersive knowledge expansion for us. It was really wonderful, learning and listening all the resource persons. They all offered so much to learn. With this, I have only one query, that we are getting mails of these videos also. So up to when we can access these videos, or are they going to be there for a longer period of time, or they are going to, shift from their platform to somewhere else?
Generally, like for 1 month, they remain on Zoom, and in course of time, we also converts them into YouTube links, and they become if you see the previous 2 courses on engendering healthcare and medical education and gender medical education and healthcare system, all those videos are now available. So immediately we are sharing with the participants the video on Zoom, but they will in course of time will be channelized through YouTube.
Okay. Thank you so much, ma'am.
Thank you so much, ma'am. Is there anyone else who would like to go ahead?
Hello.
Yes.
Yes, Vaswani.
In addition to the recorded videos that we are getting on our emails, is there any written study material available?
We have given you, no? All the links of this written material we have given. Each and every speaker has given PDF file, which has been shared. If you see the booklet, there'll be links for the printed material written by either the experts themselves or they have given the references.
No, actually in
Have you
mail,
received the PDF file? It was sent by mail to everybody.
no, I would like to know from other participants because the mails I am getting have the links only to the videos, not written study material.
PDF file.
Huh?
No, we got it. We got
shared
it.
with you.
Yeah, yeah,
The dossier.
we have received, ma'am.
Ma'am,
Yeah.
if I can take this, Varsha ji, we have shared a document by the name of course outline and reading resources.
Correct.
You'll find it at the bottom as an attachment to the mails. We have been sending them to you with each video as well. So you'll find it there, and at the end of the document, there is a whole page dedicated to the reading resources itself with links to open access resources. So that is where you'll find all of the reading material that you need.
Okay, okay. Thank you
Just
so
check your email attachments. It is there. Yeah.
Yes, sure. Thank you, ma'am.
ईमेल में पढ़ेंगे ना तो लास्ट में जाएंगे तो वहाँ पीडीएफ दिखेगा वीडियो वाला ईमेल भी
Thank you.
लास्ट में
Are there any other audience members who have any questions or have any comments or suggestions? Seeing none right now, I request our chair for the event, Professor Vibhuti Patel, ma'am, to give her closing chair remarks.
Yeah. And I think I won't take much long because all the presentations over last 4 days have been so comprehensive with so much of case studies and perspective. But the larger rubric under which we have seen the whole issue of reproductive and sexual rights of women is a right-based approach, and also the overarching commitment to the reproductive rights as human rights and response to intersectional vulnerabilities of not only girls, women, but also gender minorities. So I think these are the major highlights. And we have also talked about most of the people from the medical profession, they talked about the preventive care also, and also healthcare systems response. At the same time, sociological, ethnographic, anthropological, legal aspects of these issues were also discussed. And when we talk about the Indian perspective on reproductive rights, we need to additionally take account of several other inequalities and contradictions, which also came out in most of all the sessions, and the question of cultural values, people's mindset, some of the normative behavior, gender norms, all of them play very important role. So, and also the larger political economy, where the question of all, I think several experts also raise the issue of basic amenities which the people need, whether it is a question of drinking water or basic facilities or sanitation facilities, which has a direct relationship with the sexual and reproductive health issues. So it is very important that when we to focus on women's reproductive rights, they have to go beyond reproductive freedom and enter into the arena of socio-economic and legal rights. Thank you very much. And we salute all experts for their commitment, for the research findings which they shared, and path-breaking contribution they have made in the field of sexual and reproductive rights. And so readily they agreed to share their knowledge with all of us.
Thank you so much, ma'am. I now request our co-chair of the event, Dr. Manorama Bakshi ji, to add her closing chair remarks for the session.
मुझे लगता है रीत आई थिंक विभूति पटेल मैडम ने पूरा अच्छे से एलॉबरेटली समराइज किया अबाउट द प्रोग्राम एंड taking from this, course. I don't think I need to add anything here. Thank you so much. It was a wonderful
Thank you,
program,
Madhuri.
hearing the panelists as well as the questions I had. Thanks. Thank you so much.
So our
Good
team
learning
was very
experience.
effective, and I must thank you also for we have both complimented each other. That was very important experience of working together. Yeah.
Thank
So
you,
this
ma'am.
is what
Thank-
has been, yeah, thank you. This
I
is
look forward to ma'am very closely working with you
Yeah.
and
in
learning
future
from you,
also.
ma'am.
Yes.
जी ma'am, बिल्कुल IMPRI के साथ. ठीक है ma'am.
Thank you so much, ma'am.
So Varsha ji, this is what has been shared. The whole document is there, and you will get all the further readings. See, this is what. These are the links. If you click on them, you will get the PDF file of all the reading materials. There are articles, documents, various this thing, and some booklets also. Yeah. They all are sessions.
Thank you so much, ma'am. Now, I'll be concluding the session. So, as we come to an end of women's sexual and reproductive health across a lifetime, an online national summer school program, a 4-day immersive online certificate training course. I, Reetlath, researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI Gender Impact Studies Center, New Delhi. We are grateful to our experts for Day 4, Professor Vibhuti Patel ji, Dr. Manorama Bakshi ji, Dr. Sangeeta Rege ji, Dr. Amar Jesani ji, Dr. Anant Bhan ji, and Dr. Sanjida Arora ji for taking out their valuable time and giving an opportunity to the participants to learn from this online certificate program. As you draw curtains on this enriching 4-day-long course, I extend my heartfelt gratitude to all our distinguished speakers for their unwavering commitment and invaluable contributions. Your dedication to sharing your profound insights and expertise has been the cornerstone of this educational journey, enriching all of us with a wealth of knowledge. I especially would like to thank the chairs of this event, Professor Vibhuti Patel ji and Dr. Manorama Bakshi ji, for their unwavering, constant opinions and perspectives on different topics throughout the course. Thank you so much, ma'am. I also wish to express my sincere appreciation to each participant for joining this intellectual voyage. Your active engagement, thought-provoking questions, and enthusiastic participation in our discussions have significantly enriched the depth and the quality of our deliberations. We look forward to welcoming you to more future events like these. Again, please note that the feedback session form will be shared with you. Do fill the form so that we have a better idea on how to improve our future courses. We are grateful if you're watching us later on YouTube or listening to us on our various podcasts or reading our publications. We hope you continue to join in to future IMPRI Web Policy Talk and Policy Learning. Wishing you a very good evening. Thank you, everyone.
Thank you.
Thank you.
Thank you, Reem, for
Thank you, ma'am.
conducting the program so well.
Thank you so much, ma'am.